We go live now, please. And we are live. So welcome everybody to this second board meeting of the Integrated Care Board for the North East and North Cumbria. We have a very full agenda today. I'd like to introduce some members of the board who were not able to be here last time or are standing in their roles. So first of all, to welcome our fourth independent non-executive director, Hannah Bowe, who was in transit to being appointed at the last meeting, so she wasn't there, but some of you have met her since. David Purdue, our Executive Director of Nursing, who was finishing off in his previous job, and therefore this is his first meeting. And then David Chandler, who is acting Interim Director of Finance, and Nicola Bailey, acting in a similar role, covering the commissioning functions role in the northern part of the ICS. Apart from that, we have some apologies for absence, which I'll ask Deb to go through.
Thank you, Chair. Yes, so we have apologies of absence from Catherine McAvoy-Carr, a Local Authority Partner Member, Anne Workman, Local Authority Partner Member, and Ken Bremner, our Foundation Trust Member. Thank you.
Are there any declarations of interest for the purposes of this meeting? As we mentioned at the first meeting, we are developing a substantive declarations of interest form with advice from the Good Governance Institute and also looking good practice elsewhere. So shortly we'll be able to have a published declaration of interest for all members of the board and also deal with associated matters such as the receipt of hospitality and the things that you would expect to see in a public board of this sort. So we turn now to the minutes of the previous meeting held on the 1st of July. Are there any points of accuracy in the minutes before we turn to matters arising? Jacqueline.
Thank you, Chair. Just on the section relating to the integrated performance report.
You need to go a bit closer to the microphone.
On the section relating to the integrated performance report, there's just a couple of small changes that need to be made. On the section relating to the performance against the 4-hour urgent care target, it states the national performance where it should be the ICB performance. I've drawn this to the attention of Deb and we'll make the correction after the meeting if that's okay, Chair.
Thank you very much. Any other points of accuracy on the minutes of the last meeting? If not, can we please turn to the matters arising? And the first one is the Health Inequalities Task and Finish Group. And that's Neil O'Brien's going to talk to that.
Yes, Chair, I can update on that. So we've been doing a piece of work looking at the governance of how we manage health inequalities, prevention, population health management. We're preparing a paper which will come to our exec probably in the next couple of weeks and then up to board. We're trying to, there's lots of people who are involved in this across local authorities, the health service, voluntary sector. And over the last few years, we've successfully managed to get all system partners together to work in that way. And we're just trying to tighten that up a little bit and make sure that it's well connected into the governance of the ICB, because one of our big priorities is reducing health inequalities and delivery of the core 20+5. So that work's underway. There'll be a further update to next board, where we'll also be able to update our recommendations for the spending of the National Health Inequalities money.
Thank you, Neil. Are there any points anyone wants to raise in response to that progress report? No? And then we move on to the policy review schedule.
Thank you, Chair. At July's meeting, we agreed to review all of the policies to ensure they reflect the ICB ways of working going forward. Given the number of policies, it will take us some time. We've pulled together a prioritisation review schedule, and it has been prepared for the Executive Committee, which will be taken in October. We will bring a further update to board in the next few months, just to update everybody on where we are. You've already mentioned some of the work that we're doing with the Good Governance Institute too, that we'll be able to update people on too.
Yes, you may remember this was a very big bundle of papers that we received at our first meeting, and many of them were to do with clinical policies, actually, that the clinical commissioning groups in the North East and North Cumbria were operating. And so some of them were in need of bringing up to date anyway. They would have been formulated, you know, over the course of the decade that the clinical commissioning groups were operating. Some were updated and changed and others weren't. So it's an important area of work, but as Claire Riley has said, there's a lot of work in each single one, and there were a large number. So we're working our way through them as quickly as possible, and then you'll get a report from the executive group, the executive committee, on how that work has concluded and what you need to know in any sort of detail. Are there any other matters arising that we haven't listed on the agenda? Thank you. So if we could move on to our Chief Executive's report, and Sam Allen, Chief Executive, is going to present that.
Thank you, Chair. Good morning, everybody. So my report is covers particularly around sort of key national issues and local issues. Chair, if I could take most of the report as read, but I do just want to pull out a few key points, and starting with the quite significant changes that colleagues will be aware of due to changes in leadership in the government, and particularly in the health and social care department, where we do have now a new Secretary of State for Health and Social Care, the Right Honourable Therese Coffey, who was also the Deputy Prime Minister, those changes being made in early September. And since that time, a new ministerial team has been appointed, and the Secretary of State has published in full the government's plan for patients that colleagues will have heard trailed in the national media along the lines of the A, B, C and D. A for ambulances, B for backlogs, C for care and D for doctors and dentists. If I could just briefly, Chair, just share a few of my reflections on that plan. I think the first thing to say is that this is a plan that's been published for patients. And really at the heart of the plan is about making performance far more transparent across the health service. So in terms of ambulance response times, for example, in terms of waiting lists and how we're clearing the backlog of elective care that has built up, particularly over the last couple of years due to COVID. And also we look forward to what has been widely trailed as the forthcoming workforce plan. We can expect the performance here in the North East, North Cumbria, to be published, to be compared nationally, and for the government and the Department of Health and Social Care to place real accountability on what they are referring throughout as the local NHS. And my interpretation of that, Chair, is the Integrated Care Board. So in terms of us and our accountabilities to our population, in terms of addressing particular challenges in relation to performance, in relation to access, and particular focus around access to primary care, and contact within 2 weeks for people who request it, and telephone contact being easily accessible for the public. These are some of the areas we can and should expect the government to place very close scrutiny on. And I think in doing so, looking at not just the performance, but the productivity, looking also at prevention, but also how we meet public expectations. And I think here in the North East, North Cumbria, and indeed at our first Integrated Care Board, we talked at some length about primary care access. Over 70% of our GP appointments now being seen face-to-face, almost having recovered pre-pandemic levels of activity. Having said that, we know that there is a public, there's a delay and a lag sometimes in terms of public perception. So, Chair, I'm really pleased that through our integrated performance report, we've captured our performance against ambulances, we've captured performance with our cancer treatment in terms of the elective recovery. Where we need to develop further is particularly around workforce and a local workforce plan, but also how we're addressing challenges, particularly experienced nationally, with ensuring that people are receiving the right care in the right place. And I think for us here in the North Cumbria, some of our particular challenges at the moment are particularly in relation to social care, and working very closely with our local authority partners, because we know that these issues are really related to issues such as the market management, looking at the supply of available workforce and suitability of the right care packages, and making sure that we've got those available to our public. So we know that the government has announced an additional £500 million coming to support this, which we're currently waiting further detail on at the moment, and we will be working very closely with our local authority partners, particularly in areas where we have some real challenges with regard to availability of the right care in the right place. And if I could particularly highlight North Cumbria as an area that's under some quite significant pressure at the moment. So the new plan for patients is one that we are using to align to all of our local planning. We've been building additional capacity through our winter plan, working with our NHS providers to support this. But we do know that we need to look at capacity, particularly in the community, particularly with social care providers. So the resource will be welcome to enable us to do that. Chair, if I could just then go on to mention 3 brief points. My report touches on the work we're doing as an integrated care board, having assumed the responsibilities of the 8 clinical commissioning groups here in the North East and North Cumbria. We do know that we have some quite significant work to do, particularly around ensuring that we've got access to evidence-based practice right across the North East and North Cumbria. And the particular example of that would be the implementation of NICE guidelines and evidence-based treatment for our public. It is perhaps unsurprising when you inherit the work of 8 organisations that there have been differences in decision making, some of which absolutely relating to prioritisation for the populations the clinical commissioning groups serve. But now we are the North East North Cumbria Integrated Care Board. We are doing work to understand where we've got variation in practice. And then just finally, delighted last week for 2 very significant events. Firstly, we had our inaugural integrated care partnership, which I think went very well and is available to view on our public website, along with the papers of that meeting. Whilst some of the matters were procedural, I think the partnership, which is a partnership of our health, our local authority and our community and voluntary sector partners, really set out an ambition through the development of our integrated care strategy for the North East and North Cumbria to really focus on health inequalities. So I'm delighted that our Medical Director, Dr Neil O'Brien, has taken that work forward. And then just finally, we had our inaugural Learning and Improvement Network event in Newcastle, widely attended from colleagues right across the North East and North Cumbria, patient and lived experience testimonials being at the heart of that. And if I could just say, in terms of our learning improvement system, whilst if I reference back to the new Secretary of State's plan for patients being very much focused on performance and productivity, I think one of the things we've recognised here in the North East and North Cumbria is that culture, really nurturing an improvement and learning mindset in a way that can use data, use evidence, but most importantly share practice so that we can, where necessarily, scale that, adopt it, but get the learning into all parts of the North East, North Cumbria as quickly as possible is our ambition for our learning and improvement system. Thank you, Chair.
Thank you very much, Sam. I'll throw it open to questions and comments. I'd like to just maybe pick on the themes that Sam has highlighted, and then I'm sure there'll be a number of you around the table that want to comment. But if we could start with the winter pressures resilience, and this is obviously linked into the whole question of pressure on the NHS with accident and emergency departments, waiting times, ambulance delays. So it's a question of anticipating winter in the sense, is the pressure likely to get greater or stay at its present level? But then I just wondered if you want to say a little bit more, Sam, and maybe some of the other executive directors might want to chip in, about trying to unravel the causes of these pressures, because they're going on all over the country, clearly, and the common causes would include difficulties of discharging patients into social care. But I just wondered if nationally, in the ICB team, we're getting a better understanding of the root causes and the potential for them to be dealt with. And maybe I could ask Jacqueline Myers to come in first on that point, and then you might want to ask any points of your own. Go ahead, Jacqueline.
Thanks, Chair. So in terms of getting to the root causes, I suppose I would preface any remarks by saying it is complicated and multifactorial, and work is still going on. And we've got a presentation later from Neil that no doubt I'll chip in on as well around the actions that we're looking to take as we approach winter. But to try and summarise the kind of, if you like, largest causes, it's a combination of delays for ambulances when they reach hospital emergency departments, and that tends to be delays right through the hospital pathway. So commonly emergency departments will have patients who are ready for admission and should be moving on to hospital bed, but because there are no beds available, they stay sitting in the emergency department. That blocks cubicles, and that comes right back to the front door. So ambulances are experiencing handover delays, and that's a picture right across the country and also locally that we monitor very closely. But the other side of the coin is that there is increasing numbers of ambulance calls being made, both to the 111 service and to the 999 service. And I think understanding the drivers for that is something that we need to do more work on, but it's no doubt, at least in part, due to ageing population with complex needs and pressures on all the services that might meet their needs, for example, social care, as Sam has referenced earlier. I thought it might be just useful to give a little bit more context on the national picture. So I've just pulled up the latest ambulance response times, both nationally and locally, because I thought it might be helpful for the board to see that picture. So I'm looking at a table that looks at the 11 ambulance services across England and the 4 categories of response times, just for the benefits of those who might not be so familiar. Category 1 are for life-threatening injuries, and at least 9 out of 10 times we aim to respond to those within 15 minutes. Category 2 are the next level of emergency, and 9 out of 10 times we look to respond within 40 minutes. And then for Category 3 and 4 calls, which are calls of lesser urgent nature, the aim is to respond 9 out of 10 times within 120 minutes. Now, nationally, no ambulance service is meeting the response times for Categories 2, 3 and 4, but I also have the ranking, and the North East Ambulance Service ranks second out of 11 for Cat 2 and 4 and third out of 11 for Category 3. Only the Isle of Wight Ambulance Service is doing better. And in terms of the most life-threatening calls, the Category 1, I'm pleased to say that NIAS is one of only 4 ambulance services in England that's still meeting that target. In fact, they're second out of 11. So for our most seriously ill patients, we are still delivering the ambulance response time, despite the delays that I mentioned earlier. But it is a pretty uncomfortable picture, I would say, and you'll see when we get onto our plans around preparing for winter that we're focusing very much on how we ensure that the ambulance can attend to patients and drop them off in a timely manner. Don't want to steal the thunder that we'll look at there, but I think as well as looking at optimising practice around handover, it is around only sending those ambulances to hospital that absolutely need to go and trying to connect to a wider range of services that can meet the needs of patients who call either a 111 or a 999 ambulance. So I guess that would be my very quick summary, Chair, of where we stand at the moment.
Thank you. That's a helpfully amplified that point. Are there any other comments on that specific issue? And we'll turn to other points in a second. You want to say anything else about that, Sam?
Just briefly, Chair. Just to say that in terms of you asked how long is this going to go on for, I think was one of the points I picked up, which is I think the pressures on the service are going to be there for some time. We know that particularly around our elective recovery backlog, we're looking at working on that particularly over the next couple of years. Again, not wanting to go into too much detail at the moment because I know Neil will cover this, but the three key actions the systems come together, both health and social care, to really focus on as we head into this winter is building capacity. So we have expanded our capacity through our acute hospitals. As I've said, with the additional funding that's coming through, we'll be looking to do that, particularly in social care too. Earlier clinical triage so that we can get patients to the right place. And I think, as Jacqueline said, we do want to reduce the number of people that perhaps are not unnecessarily so, but at the moment there are no other options for them. If we can do more prevention work in the community to prevent the conveyance to hospital when that's not needed. But then just finally, a call to action really, particularly working with our public. And colleagues will know that I wrote to Ofgem recently, particularly around signalling our concern about the clinically vulnerable and particularly looking at the cost of living challenges that people are expecting, but really making sure that we've got as much information as possible out with our public, with our community and voluntary sector organisations to ensure that we're signposting people to the right support as early as possible to prevent crisis.
Thank you. Jane.
Work. Can people hear me?
Yes, a little bit. Just stay close to it. You're about right. Don't fall back.
Okay. I'm Jane Hartley. I'm the voluntary and community sector representative representing our North East and North Cumbria VCSE partnership programme. And I really welcome your report, Sam, and I particularly welcome item 3.3, which talks about an appetite for thinking differently regarding funding streams to support grassroots activity, including via a charitable foundation or other income-generating mechanisms. And also this has a relevance to the winter pressures agenda as well, I think. I just wanted to, for information, because this was developed through working with the previous ICS workstream leads and clinical networks, but through our partnership programme, we worked with local community foundations in the North East, and we developed a protocol around supporting a democratic and effective way of distribution of NHS funding as it came into the then ICS to support, which was to be spent within the voluntary and community sector. And we have some really positive examples. John will back me up on this, around supporting distribution of winter pressures funding, mental health transformation funding, and latterly the NHS Charities Together Community Grants Programme, which required ICS intelligence, if you like, on how that funding should be spent. So I really just wanted to say that we have that protocol, it has worked, and don't throw the baby out with the bathwater. Come and talk to us about it, and particularly as those of us who've lived through winter pressures funding coming incredibly quickly, needing to be spent incredibly quickly, that actually if you do wish to take a community approach, having that protocol to be able to distribute the funds and take a preventative and community engagement approach, then I hope will be helpful. Thank you.
Thank you very much, Jane. David Thompson from Health Watch.
Thank you.
Your microphone, David.
I beg your pardon. Thanks for your report, Sam. But if I could mention something specifically on dentistry, which on the scale of things compared to ambulance service, etc., is not particularly high on the agenda. But I notice in the report it mentions that funding, when it is delegated, will be at historical levels. Could I mention that one of the major issues currently within dentistry is the perceived underfunding of the service, and should the funding remain as it is now, then that will simply exacerbate the inequalities being felt within significant areas of the population. And the second issue, a particular question, I think you mentioned that you may seek to delay accepting the responsibility for dentistry for another year. Is that a fair comment or not, might I ask?
Thank you for raising those points, David. You're absolutely right. Certainly, consistently, one of the key things patients are telling us, and Health Watch indeed, is around access to NHS dentistry being an issue in some parts of the North East and North Cumbria. As the paper says at the moment, that is the commission responsibility of NHS England. The plan would be to delegate in April 2023. It may be that we take that in shadow form for a year, so we do get involved in it, but perhaps we don't take the responsibility for the resources. It's still too early, but we're working through these conversations with NHS England at the moment. I think for us, given some of the historic issues with funding, I think we do need to be very clear on what we're taking responsibility for, and that we've got the available resource to meet our population's needs. Having said that, we wouldn't want to delay getting involved to be part of addressing this issue. And at the moment, working with our colleagues in NHS England, North East, North Yorkshire region, we've requested a picture of the available activity capacity at the moment, numbers of registrations with NHS dentists and the locations of them, so that we can get an early picture of that.
If I could just add, I would welcome, an urgent look at the accepting the delegated responsibility, because of all the issues which Health Watch Northumberland receives. Dentistry is clearly the aspect which is most exercising the minds of the wider public at the moment. It's a very significant issue, and as I mentioned before, I think it is adding to the inequalities which many of the disadvantaged people are already facing. Thank you.
Thank you. And Dave Gallagher, who's Executive Director of Place-Based Delivery for the central and south part of the ICS. Dave.
Thank you, Chair. And yes, dentistry crops up as one of the most talked about things in health and wellbeing boards as we work across the patch, so the pressures are there. The delegation of dentistry, optometry and clinical pharmacy provides some huge opportunities in terms of getting the system right, but equally brings some challenges. So just to assure the board, we're doing a very, very detailed piece of work over the next few months under the banner of due diligence to make sure we understand exactly what we would be taking on, and being really clear with NHS England colleagues of what we would require to take on the responsibilities, particularly but not exclusively of dentistry.
Okay. David Purdue, Executive Director of Nursing.
Thank you, Chair. In terms of our system quality group, it is on the agenda for our next meeting around dentistry, particularly access for child dentistry as part of our inequalities work. So it is very much for and centre of kind of the work we are undertaking.
Thank you very much. We need to leave this item now, but just to say, I think that there are some very interesting things in Sam's report, and I've concentrated particularly on what's sometimes called the performance management side of the agenda, because of the great pressures in the NHS across the country and in this part of the world as well, and the importance this has for patients getting access to services when they need them, with the backdrop, of course, of the amount of backlog of work that accumulated with COVID, which is now being tackled very, very vigorously. But I did just want to say, though we won't have time to discuss it much today, that the other point that Sam made about the event last week, which some of you attended, which brought together a very large group of people from right across the ICS who are focused on quality improvement activities. Now, this may sound a bit technocratic, but in fact, the content of the meeting was very rich in and ran into some very deep themes of need. And particularly, I point out the case of child and adolescent mental health, which aroused a huge amount of discussion, huge amount of compassion in the group. So it is, in addition to dealing with the urgent and immediate, we're absolutely determined in the work of the ICB and the ICS as a whole to preserve space for the important developmental function that the ICS has been given, both in relation to care and patient care and quality of patient care, but also obviously population health and inequalities. So we want the urgent to be important, but we don't want it to overwhelm us to the extent that we can't do this vitally important developmental work, which is all about partnership and integration, and just trying to do better against a backdrop of some very good standards already. But it's always possible to go that further mile in the quest for moving from good to great, really, which is what we want to try and do over the medium and long term. So a little bit pressured for time on your report, Sam, but there's a lot of interesting stuff in it to be read about as well. And I can move on now to item 8, which is briefly to ask Claire Riley, our Executive Director of Corporate Governance and Communications and Involvement, to just highlight some of the points that were made in our analysis of feedback of the last board meeting.
Thank you, Chair, and thanks for everybody who completed the questionnaire that we sent out. We've got a few themes, really. What worked well, excellent chairing, so there was a lot of positive comments about the way that it was chaired, with a clear agenda and really good participation from all members. The feeling was very positive from a meeting point of view, but overall good engagement. What could go better? Obviously, people commented on the bundle of papers, and we know that there was an awful lot of papers there, but also recognition that it was a one-off because of the nature of where we are in our creation. There were some comments around slides, that some of the information was too small for people to read, and some comments around the setup of the room, the microphones that we're working on just to improve. From an improvement point of view, there were a few comments around structuring the agenda to align to the ICB strategic aims, and also inviting suggestions at the end of the meeting for future agenda items. And one final comment was to really look at some reflections at the end of the meeting to see if any board members have any further reflections to share. Other than that, really positive comments, Chair.
Any points anyone wants to raise on that? And obviously you can please continue to feed back both formally and informally. We very much welcome that. And the next item is yours as well, Claire. This is about amendments to one of our committee's terms of reference.
Yeah, thank you, Chair. It is only a slight amend. We recognise there was an issue with quoracy. We have made that amend, and it is presented to the board for approval.
Thank you. Is everybody content with the proposal? Thank you very much. So that's accepted. Moving on to item 10, and handing to our Chief Executive, Sam Allen, again for this one. And this is really, for those of you listening on the line and not familiar with it, our team of executives, led by the Chief Executive, meets very regularly to go through a wide range of business, and that is brought together in a formal subcommittee of the ICB, and it's important for the main board to be aware of the business that's conducted there, and on some occasions bring items forward which don't necessarily overlap with the agenda of the board, so that they can be discussed further at the main board level. But Sam, over to you.
Thank you, Chair. And just to say as well, for fellow chairs of committees of this board, hopefully this serves as a useful way of making sure that we're joining up the dots between matters that connect our committees together. Chair, I won't go through the report in detail. I think it's pretty self-explanatory. We have one thing I just want to note is we have had one further meeting of the committee since the July meeting, and we will circulate the notes of that to all members of this board so as to not to delay them until the next meeting. Thank you.
Thank you. Are there any points anyone would like to raise? Just a couple of things to highlight on the key point summary of the committee's work, which I think will be of interest. Firstly, the proposal for the community diagnostic program, which is ongoing, but it's increasingly these services based in the community, I think, are going to be a very important part of the work of the health service, particularly in the North East and North Cumbria. And secondly, that there was a national requirement to review implementation of some of the guidelines of the National Institute for Clinical Excellence. And that is something that Neil O'Brien has been coordinating, our Executive Medical Director. But I think something that will need to come back to the board, because there's an interesting debate, I think, to be had about the extent to which the NHS across the country has the capacity to implement what are regarded as mandatory guidelines from NICE, and what happens if the capacity just isn't there in some of the services where mandatory guidelines have been recommended. So it is an important area. We're still gathering information on the situation in the North East and North Cumbria, but we will be coming back to a future meeting to address that. Okay, thank you. Any other points there that anyone wants to raise? So moving on then to further detail on urgent and emergency care and resilience, which Neil, oh, I'm so sorry, I've missed item 11, which is the report from John Rush, the committee chair of the Finance, Performance and Investment Committee, which is one of the subcommittees of the Integrated Care Board.
Thanks, Chair. And it's I don't know what that is, but I'll move that out of the way. Yeah, just very briefly, it's very similar to the report.
We're going to change your microphone, John. There's no allegation that you were clicking your pen, but there was a problem with it.
Or sighing, hopefully. Just really quickly, it's just to outline, before we bring it back formally to the board at the next meeting, just some changes we wanted to make into the Finance Committee. And primarily it was around, it was a little bit cumbersome when we did our first meeting, and the idea that we'd probably have 2 meetings involving finance directors from across the providers, when in fact we spoke to John and later on to David, to work out that actually there's already a meeting that takes place that the Executive Director has with those individuals on a regular basis. So that was one thing about it. And then the other thing was we just felt we could condense it into one meeting and involve obviously our FT representatives in that meeting. And it was so people are aware that we will bring back an amended report, an amended terms of reference, and then people could see it in full. But we just felt, after speaking to everybody, it was concerned with the meeting that was going to be the best way to do it. So it's really just to warn people and advise them what we're going to do. That was all.
Are there any comments anyone wants to make about that? David? Sorry, who? Oh, yeah, Claire Riley. Sorry.
No worries, sorry. John, it would be good just to have a discussion about it, if that's okay, just before we do anything.
Oh, absolutely. That was the purpose of bringing it, really, so people were aware. Yeah.
Okay. So the nameplates are blending in with the water bottles as they did in Sunderland for some reason. So sorry I didn't pick you up immediately there, Claire. Okay, we move on, and we are now on the item where we trod on your territory a little bit on this paper, Neil, earlier on, but this is a full look at urgent and emergency care and the operational resilience plan.
Thank you, Chair. So today I'd just like to focus a little bit on how, as an ICB, we are looking to try and manage the surge and our resilience as a system going into what we are expecting to be a challenging winter. I'll talk a little bit about our priorities and about some of the changes that we're making in order to manage the system. So this chart, which you may probably can't see because it's quite far away, we've refreshed our governance, and broadly the way in which we are managing the urgent emergency care network is from the bottom up, in that all of our places are involved in something called LADBs, which are local A&E delivery boards. Now, they are partnerships of place-based leaders from the health service, from foundation trusts, from primary care, voluntary sector, local authority, that really do focus on this agenda. We've, through the Urgent Emergency Care Network Strategic Board, which is the red square in the middle there, that's the group that I chair, we're refreshing the terms of reference for all of them. And actually, we've looked at the leadership of these groups, and they're now all chaired by chief executives of the foundation trusts, which I think is appropriate with the level of importance for the work that they need to do. We've also looked to improve our clinical involvement within the oversight of the urgent emergency care system by developing a professional network or a professional group, which will be chaired by David Purdue, our chief nurse. We've got significant support from NEX. We've got strong links with our provider collaborative, but essentially the network, the Urgent Emergency Care Strategic Network Board, will feed into and report into our ICB Executive Board, which then reports into here. So it's important we've got quite a simple way of managing the system, and I think it needs to be simple. Some of the priorities that I'm going to talk about later are the priorities that we're looking at a system level, the things that we can do once across the system. But there are a whole host of other priorities that are being implemented through our local A&E delivery boards, which I won't go into the detail of today. And how we manage surge, previously to the ICB coming into operation, the CCGs did have a surge rota which basically had some directors on call, but it had one director on call for the whole of the North East and North Cumbria. We're currently going through a consultation process with our staff to increase the capacity there, because we're expecting there to be more demand on our on-call rota as we go forward. We're looking at 2 tiers of director on call, a strategic and tactical, and the tactical will be based upon our 4 ICP areas. So that those directors will hopefully have some intricate knowledge of local systems, so they can advise if there is a particular issue within surge.
Sorry, Neil, just before you go on, if you could go back, please. And just on the second bullet point, just clarify those acronyms, RADAR and Optica, what they are. So everybody will know.
RADAR and Optica are basically IT systems that we can use to monitor flow through hospitals and urgent emergency care pressures, such as ambulance handover delays, A&E waiting times, which is available on an app that we can see real live information.
Okay, thank you.
So I'm going to talk about 3 priorities that we have decided as a system, and again we've checked these with our chief executives of foundation trusts, of things that we can do for this winter that we think will make a difference. The first one, and Sam alluded to this before, is enhanced clinical triage at the time at which ambulances are called or requested. There is a lot of evidence that suggests putting clinical triage into the 999 111 pathways are both safe, they enhance patient experience and can reduce the number of conveyances to hospital. An example of this might be an elderly person who may have fallen at home. An ambulance would normally be dispatched to them, but that would be a category 3, and they may wait for up to 2 hours to be seen. But there are now 2-hour rapid response community services that we could direct those calls to, which would save an ambulance conveyance. They could assess the individual in their home, make sure that they haven't had any particular injury that requires hospital treatment, but put support in around that individual in their own home. The current pathway was they would be picked up by an ambulance within 2 hours, and then they would be exposed to waiting in A&E and then getting the individual back a number of hours later, which is not great for patient experience. There are many other services that we can actually look to utilise to try and take the pressure off the ambulance service and emergency departments if we can just get some sensible clinical triage in the pathway and improve the connections between 111999 and all of the directory of services that we have out there. So we think investing some time in this, improving the directory of services, putting in some senior clinical decision makers in this pathway could and should make a real difference. So that is our #1 priority for this winter. The second one is primary care access. We do understand that a lot of individuals access our urgent emergency care system because of issues in getting access to their GP, and also a lot of individuals who turn up to our emergency departments would actually be suitable if primary care appointments were available. I think improving access to primary care across the board is something that we should always aspire to do, but we're focusing on things for this winter. And our focus for this winter would be to ensure that all of our emergency departments have access to primary care appointments if individuals turn up. And we should try and co-locate those on our emergency department sites, if at all possible, which would allow streaming of individuals to see GPs rather than sitting and waiting in A&E. And also, can we improve the link-up and direct booking from 111 into GP appointments or into urgent treatment centres? So that's our second priority, which we feel as though we could do something for this winter. And our third priority is around improving discharge and patient flow. There's significant funding behind this that Sam has already mentioned. David Purdue is going to lead a group which is mainly around peer review and challenge and learning around how we can improve our processes around discharge. But this is a partnership model between ourselves, the health, as the ICB, NHS providers and the local authorities, because a lot of these issues, but certainly not all, are due to the lack of availability of social care, but sometimes internal processes within the NHS actually affect our ability to discharge patients in a timely way, which therefore affects flow, and that in turn affects all the way back to ambulance handover delays and poor experience for patients. So again, we think that as a system there are things we can do on this priority, but a lot of this work is also being picked up in your local A&E delivery boards. Other significant actions for this winter: we must deliver a good COVID and flu vaccination programme, and I have an update on that later on in the agenda. Getting our communications right so that the public understand how to access the urgent emergency care system, and again we've got work underway on that. Just yesterday there was a large document which I haven't fully read yet, which goes into the plan for primary care for winter, but there are certain changes around primary care network enhanced services which may help for this winter, and we'll digest that and look to implement that. And there are a number of other actions that that again are through local A&E delivery boards, which around mental health, improved mental health support, A&E peer support, and working with the voluntary sector, which we think could make a real difference. On measures of success, we will, as a board, need to report against the 6 national metrics that are detailed on here. However, we're proposing some more local metrics which align to our 3 or 4 kind of system priorities, and that is delays of repatriation or discharge, the number of 111999 calls that we are actually clinically triaging, and then the number of those that we are managing to put into more effective or different pathways, and our vaccination rates that we will bring back to board. Sam's already mentioned our wider responsibilities as a system leader around some of the issues that might affect our public this winter, the rising costs of energy, and as I say, Sam's already mentioned the letter that she's written. So we have been requested we've been requested for the trajectories against the 6 national metrics, and we haven't really fully got the information yet of exactly what our trajectory is to be, but we're expecting that sometime next week. I've been in some calls nationally about how we manage surge, and it may well be that we are mandated to have a 24/7 clinically led operational hub for the ICB, but those conversations are very much in early stages, and we are likely to get guidance of that in the coming weeks. And if that's the case, of course, we will respond to that. Sam's already mentioned the announcement of the 500 million Social Care Discharge Fund, and we're waiting for some details of that. The access, Theresa Coffey has mentioned the access to GP appointments within a maximum of 14 days. Again, we haven't really got the full details around that yet. So that's all I was planning to present on today, Chair. I'm happy to take any questions. I really just wanted to highlight that we do have a robust system in place as a system to manage pressures, and we have some priorities, but there is also the local A&E delivery boards. I just wanted to make sure the board understood that those groups were also in place.
Okay. Just an initial question from me, Neil. In relation to your 3 priority areas, are some parts of the ICS area stronger on these things than others?
Yes.
How much variation is there really in effectiveness?
Yes, there is variation. I mean, on the clinical triage side of things, that a lot of that is happening within our main ambulance provider. So that's pretty consistent across the board, although there are some pockets of our foundation trusts that are starting to triage directly from A&E departments. So that's a pilot currently underway, and we're hoping to learn from that. On primary care access, some units do have well-established co-located services and very effective GPs streaming into GP services. That's not across the board. And discharge, yes, we do have some hospitals that seem to have particular issues around the discharge process, but we're hoping to try and level up everyone from learning through David's leadership.
Okay, I'll open it up now to board members' questions, but just to give notice to the 2 directors of place-based delivery, just I want to ask them how they're seeing things at ground level, as it were, and in particular the issues that are concerning them most in causality terms. So Eileen Kaner is one of our independent non-executive directors and chairs the board's subcommittee on quality. Eileen.
Indeed, yes. It's a question for clarification, really, and it is as chair of the Quality and Safety Committee. On the diagram of decision-making and reporting, I couldn't quite work out how this activity related to the winter surge will relate to the Quality and Safety Committee. Clearly, we're a young organisation and we're almost in winter already. It's chilly outside. So we need to do some things quickly, but also we need to look to the future, thinking preventatively about how we can set things in place. So I'd like to understand how this activity, where the decisions are being made and reporting quickly through the Executive Committee, will in due course relate to the Quality and Safety Committee of the ICB.
You want to come back on that, Neil?
Well, I think David's leading our Quality and Safety Committee. We've had some conversations about it, so I'll hand over to David.
Yes, thank you, Chair. And thank you, Eileen, for your question. I think the important bit for us in terms of any of these metrics is our national targets are a quality target. And that's where we have the overlap in terms of the Finance and Performance Committee that obviously we jointly sit on, that we can, I think, raise issues between the two. So if there's anything particular at that meeting, we should raise it and then take it back to the quality meeting for a greater in-depth deep dive. I think in terms of some of the areas in terms of harm to patients, I think that's a key area that we need to get better at recognising. So in terms of ambulance handover delays, some places report that as a serious incident, others don't. So we need to have some consistency across the ICS in terms of how we report that. And we are working with our local authority colleagues to look at actually harm of people remaining in hospital. So people think hospital are a place of safety. Actually, if you're fit and you don't need to be there, actually you are more risk. So it's looking at harm and then working out with the local authorities some outcome measures for both health and social care.
Thank you very much. Mike Smith, Partner Member for Primary Medical Services.
Thank you for the report, Neil. The question I've got raised regarding primary care, which is obviously my area of particular interest, and improved access. I agree with the hypothesis that you made that improved access will likely reduce the pressures in winter generally. But that improved access generally comes at a price of less routine access to primary care because the system is essentially operating near capacity. So it's a decision that we're making to prioritise access over things like continuity and things like more preventative care. And we're in the context of a situation where for the past 2 years, the quality outcomes framework, which incentivised chronic disease management, was stood down due to the pandemic. So already we might be seeing some effects of that. And just conscious of the fact that if we continue to prioritise access, we may risk worsening those long-term outcomes. And just to what extent are we balancing the two, and how has the thought gone into that?
Thank you. So I think you're absolutely right. I mean, primary care has a key role in urgent emergency care, but one of our largest roles is in that continuity of care and chronic disease management, which can't suffer. Which is why we've gone very much for improved primary care access at our ED sites, which will hopefully, and that along with a continuous programme of improvement to improve general practice access across the board. So we're very much focused on this winter, so hopefully there'll not be a great deal more ask on practices, if you like, because we're looking to improve the access through our urgent treatment centres and co-located. That does raise the question that there is only one workforce and we can't work 24/7. So that is an issue, and I get that. The document that I've referred to that was released yesterday has looked at the PCNDES about standing down some IIF targets, which might help release some capacity, and also some loosening around the R's rules, which might help generally capacity in primary care. But we're very much focusing on primary care access at our AD departments to try and help with flow.
Thanks, Neil. Can I bring in Nicola Bailey now, Interim Executive Director of Place-Based Delivery for the North and North Cumbria. Nicola, what are you experiencing in your encounters with this range of services?
I think I would probably echo a lot of the points that Neil's raised in the sense of across the North and North Cumbria bit of the patch, which is where I cover. You can see significant variation in the services that are actually in place. You can see major issues in terms of workforce, whether that is around social care staffing, particularly in rural areas. Sam's already alluded to North Cumbria and the issues in North Cumbria in terms of the workforce. And you can see that right across the patch, whether that's in social care or whether that's actually in primary care. But very significantly in social care, there is a real issue in terms of workforce, not just in residential nursing care, but domiciliary care, and that is having an impact on the speed of being able to support people to move out of hospital. I think something that we're not necessarily cited on and don't talk so much about is actually the issues and capacity of our mental health services to be able to cope, both in terms of recovery from COVID and increased issues in relation to economic issues that are facing families, poverty, and we're seeing a very significant increase in the number of people either presenting through A&E or presenting through mental health services, and the issues in terms of discharge through some of those services is really key. And again, there's a significant amount of variation across the patch. I think the single biggest issue in reality is about that kind of system response through the LADBs and making sure that the LADBs are collectively taking a responsibility for their population as a system rather than the organisational response. So recognising that if you live in North Cumbria or a North Cumbria resident, you're not a person of the trust or a person of social services. You're a kind of resident, and we need to come up with a system response, and that's variable but linked often to the services and workforce issues.
Thank you, Nicola. And just before Raj comes in, Dave Gallagher plays the comparable role to Nicola in the Tees Valley. How are you finding things, Dave?
Yeah, and probably some similar reflections to what Nicola's played out there, but some specifics in looking at some of the variation that Neil talked about. We've got some really good examples of GP triage and access to primary care co-located with EDs. North Tees and Hartlepool is one example of that. Equally, just further south, we've got with South Tees Hospital on the James Cook University Hospital site, we're doing some work there to actually get a UTC up and running with support from GPs on an interim initial basis, but then on a longer term substantive basis. I think the other issue that Nick picked up was discharge issues, and all across the patch, colleagues in the NHS are working very closely with colleagues from local authorities. The rate limiting fact does appear to be staffing, which is affecting everybody, which doesn't make it any easier for anybody, but there's lots of work going on there. But just as an example of working as a system, we're a system next to a system. So in my area, we've got crossover with North Yorkshire, and just been on a call this morning where some of the pressures in North Yorkshire hospitals are having an impact on James Cook University Hospital and Darlington Memorial Hospital. Now, we're a national NHS, so it's not about being territorial, but it's making sure we work with all of the right partners and players to get some of that right.
Thank you very much. So Raj Nadkarni is a Foundation Trust partner member of the board. Raj.
Thank you, Chair. Neil, I'm really happy with the priorities which you've sort of put forward. Looks like those seem very relevant to make an impact, for this winter, not just this winter, probably many of our winters. The question was about how we can make the best use of the mental health services in managing the surge. And I think you made one reference to involvement of mental health services at the emergency departments and A&E. And clearly we've had some great successes during the first year of COVID in relation to that. The other big area of impact is actually in ambulance triage, and has a huge impact on the quality of the response along with kind of how you manage. So you did say something about clinical involvement in that triage, but I didn't get anything specific about whether that included mental health along with any physical health expertise.
Neil, if you want to pick up that point and anything that Nicola or Dave said that you wanted to emphasise.
So on that point, we are still developing the model of exactly what the clinical triage would look like, and I think it's worthy of a conversation of exactly how we weave mental health triage into that, or whether or not there is a way in which there's a quick disposition to acute mental health services. I think mental health interactions with emergency departments are under pressure, and there are some patient stories where individuals are waiting for significant lengths of time, either for a bed or for mental health treatment, which is something that we do need to pick up. Again, I just want to stress that the top three priorities are not the only things we are doing in this space. They are the three things that we think we have a fighting chance of getting in for this winter. But there are pages of improvement projects that we are undertaking, and we'll carry on doing those things throughout the year. But those top three things are the things that we think we've got a fighting chance of doing this year. But I'm happy to pick up a conversation about the mental health aspect of our clinical triage with you out with the meeting. And again, I think both Nick and Dave have just reiterated that there is variation across our patch. Not all of our emergency care systems are equal. They all have different infrastructures. They all have very different pressures, which is why the main focus for improvement should be through our local A&E delivery boards working with places, and we as a system have a responsibility to get the environment right to allow them to make the local improvements that are needed.
Okay, then well, that is a good explanation of one of the key functions of the ICB that I keep emphasising. We are new, there's been nothing at this level for 10 years, and there's the opportunity for us to tackle some of these inconsistencies and variations. Sam Allen, Chief Executive.
Thank you, Chair. I just wanted to, I guess, be really clear. I don't think we can understate at this point in time the pressure on the workforce, but not just our workforce of health and social care staff, but our unpaid carers out in the community as well. So just in terms of the conversation we just had, which I think, as Neil summarised really well, this plan is around getting through the next few months, really making sure we've got that focus on those metrics, but making sure that we're measuring what matters to us here in the North East and North Cumbria too. But it is really challenging out there, and I think this is feedback we're getting on a day-to-day basis from our communities and also our workforce. Having said that, Eileen, your point, I think about we've got to think about tomorrow, the year after, which is why I think going back to our integrated care partnership, the development of our health and care strategy, our 5-year plan, is really crucial. I think one of our challenges really is maintaining the absolute focus on the day-to-day operational aspects, supporting the system day-to-day, 7 days a week, and our communities to get through this, what is going to be a challenging period, whilst also maintaining our work, as you said, Sir Liam, earlier, around our developmental aspects, but also the longer-term horizon on the strategy, because we have to really make sure we're focused on the preventative work. And I think the point around chronic disease management, making sure that we're really addressing those health inequalities, is going to be critical. Otherwise, next winter will just be tougher than this winter.
Thank you. Neil, question to you, but others are very welcome to chip in any thoughts on this one. I tend to always think in a situation like this where you're trying to solve a big problem is about those solutions which are going to produce incremental improvements and those that have the potential to be transformative. Thinking about the things that are happening, the ones that you've described, but then maybe thinking about future action that might be taken. Are you aware from elsewhere of the solutions that, if we did them, they might make a big leap forward in progress rather than inching forward, which tends to be the way sometimes in dealing with these sorts of problems?
Yes, thanks. I really do think enhancing the clinical triage in NHS 111 and 999 could have a transformative impact on the system, which is why that is our #1 priority. 111 uses a lot of protocols which are very, very risk averse. Now, I'm not suggesting we take unnecessary risks. However, clinicians with experience that have dealt with patients for a long time are much more successful at getting the right outcome than following an algorithm with 111. And there is evidence to suggest that this can have a transformative impact. So I do have a lot of hope if we can get the model for triage right, and we can get the correct seniority of staff to do that, that could make a big difference for us.
Anybody else want to come in on Hannah?
Is that okay? Can everyone hear me? Yeah. Hi, Hannah Bowes, one of the non-executive directors. Just to pick up on a few points that have been raised, really, and I guess thinking about what Sam was saying there and Eileen said earlier, just in relation to that preventative stuff, it still feels to me like a lot of the conversation, even thinking about prevention, is about prevention at the point that somebody's already a patient. And I'm just wondering how we think and move towards that longer term strategy where we're intervening at earlier points that people never become a patient, that 111 call simply doesn't happen because they've already been identified and managed much earlier. And I mean, the older population is used as an example. It's a good one for many reasons, but of course there are lots of other hard to reach groups that actually become patients because they haven't had that early intervention. I guess that's working with the voluntary and community community support services a bit more, but I'm just interested in what that's actually, where we're moving with that, I guess, what that will look like going forward.
Neil, do you want to pick up?
So yeah, that's a very broad question, and I think I'm sat here thinking of how we will best approach it. I guess there are those individuals who have illnesses that we know about, who have the potential to become to have need of the urgent emergency care system. So they'll be known to GPs. And there's a whole load of work around emergency care planning for those individuals, so that they know what to do in the event of any worsening of the condition, and good chronic disease management. It's one big aspect. But then there is that very large number of people out there who have illnesses that we don't know about, or whose circumstances make the chances of them accessing the urgent emergency care system much more likely. So, such as things, access to services, and then the wider determinants around poverty and health inequalities. Through the prevention health inequalities workstream, we're starting to get into some of this. A good example of that is the Deep End Practice Network, which are a network of GP practices. It's not, the work isn't just around the work of GPs, it's more that this is a centre point within the communities and within deprived communities to see what we can do to increase identification of individuals who maybe don't have access to primary care services, and how can we support them through social prescribing and making links with voluntary sector to try and improve the general health of that population. But we're only scratching the surface, to be honest, and I think there's a lot more work to be done on this.
So what you said, Neil, was either very interesting or very controversial, because 4 interventions have now been requested. Just in response to Hannah, and this is not talking about the whole population of people who are coming forward for urgent care, but I vividly remember when I was a medical student being in a clinic where we used to sit in behind the consultant, and he would see the patients and we'd listen. And with patients with long-term conditions or chronic diseases, what he used to say to us was, this patient knows more about their condition than we do. And that was stuck in my mind over the years, and I've often thought the amount of, in a population that's got a growing prevalence of so-called chronic diseases or long-term conditions, the acute episode happening as part of that long-term illness is probably placing a high pool of need, and maybe we should spend more time talking to the patients with those conditions about the best way to try and prevent and control their condition so it doesn't become acute. Mike Smith, Primary Care Medical Service Partner Member.
So just in response to Hannah's point about how do we prevent patients from have people becoming patients, I think there's an example of a real positive that's already been achieved from the ICB in Sam's letter to Ofgem. There's a study in Japan after their energy prices rose after they turned off the nuclear plants after Fukushima. And they saw, with a 30% rise in energy costs, they saw a 5% or 6% rise in coal-related mortality. So we can probably expect to see similar if we don't intervene here. And I think recognising those problems early, and then it'll probably come down to working with our integrated care partnerships and our partner organisations to try and help prevent some of those avoidable deaths over the winter.
I'll group the questions together, Neil, so then you can, because we've got an eye on the time. Annie Laverty, who's Executive Director of People.
Minor comment, really, just to make the link back to the early item and the reference to our learning and improvement community. So that opportunity that took place last Wednesday, and a really, really broad representation across the system, from provider organisations, local authorities, community, third sector representation there, and patients and recent lived experience of health and social care themselves. But no surprises then when we asked people what the priorities was, just to identify that the top 5 that came out were, apart from a desire and a strong request that we do something radical around mental health and children and young people and adolescents and young adults in particular, but work around discharge, prevention work, working very differently with community and third sector organisations and with an eye on prevention. I mean, all of those five items, the top ticket items that were voted for in the room. So I think there's an opportunity for us, the way that we build that network, the way that we share ideas and best practice across that, and have an opportunity to do transformative work that means we're not just doing incremental improvements, but making radical change for people across North East and North Cumbria.
Thanks, Annie. Ajiz Zahid, who is the Executive Director of Innovation.
Thank you. In the spirit of our ambitions to become a learning system, I think there's, listening to those 3 priorities, I can see tremendous opportunities for learning here that we really need to capture and also share with some of our partner organizations like the Academic Health Science Networks, who might have sight of solutions that are out there being adopted in other parts of the country, that we could bring some of those transformational change type, innovative ideas into the system. So I think over these 3 months, of course, we've got to deal with the urgency of the situation, but I think let's also use this as an opportunity to try to capture as much learnings so that we can bring in possible solutions for the future as well. And if there's any way that I can support in that area, I'd be really keen to. On the second priority that you mentioned, Neil, I'd be really interested to understand if there's opportunities for community-based pharmacies to play a role in helping to address some of those pressures around primary care, and if there's any innovative ideas that we can bring there, that I'd be really keen to help support in that as well.
Okay, thank you very much. Next to you, Jane Hartley, representing VON, the voluntary sector.
Hello. Just a couple of points, mainly in response to Hannah's issues around prevention and working with communities earlier in their journey. Really just to say that I would say one of the drivers for that, because I also have a role around, I represent the voluntary and community sector, but also I'm the social prescribing lead within our Population Health and Prevention Board. And I would say that the personalised care DES is very clear within its 22-23 ask or requirements of primary care networks that they actually develop shared plans around targeting our most disadvantaged communities, working with voluntary and community sector, but also people with lived experience, picking up your point about patients may know best what they need. And I think we've got very, very patchy response and approach to that. And I think one of the problems we see is that dare I say it, primary care networks are not necessarily held to account for how they have developed those shared plans. And we have some great examples of collaboration and partnerships at place and neighbourhood level, but we also have some gaps. I think the Deep End network work really helps that agenda, but I think we've got a long way to go. But I would see, if we have this driver, this thing called the DES, which is their contract and they're required to do it, it's a shame that it's not being consistently approached. I would also say that we've got a really interesting pilot scheme, which I was mentioning today, the other day, which we're working through some national funding and collaboration, which is a Warmer Homes initiative, which is bringing together kind of warm homes. It's the National Energy Action, NEA, and I can't remember the name of the government body that is involved. It's something weird, but it's a programme which is looking at working with primary care around supporting referrals of people with particularly COPD, but long-term conditions within a particular disadvantaged area who will be on low income, and looking at taking warm home initiatives and actually providing funding to pay their winter heating bills for a period of 6 months, and then evaluating as to whether they have made less of a call on the NHS as a result of that. So we're actually working with a PCN in Middlesbrough to actually pilot that in this area. They've picked 3 areas of the country, Tees Valley being one of them, and it would be very interesting to see the results of that, and I would hope that might inform some further work. Finally, I just wanted to mention that we've
also... Need to be brief, Jane, because we're running out of time.
There is a piece of work that's been commissioned through our personalised care work stream of the ICS, which is looking at carers' experiences of discharge. And the report, we look particularly from the acute hospital settings, and we're working with Northumbria University. It's a piece of work across the North East, North Cumbria, but also Yorkshire, the Yorkshire region. And a report and a toolkit of best practice is being produced by the end of the year, and what we would hope to see is some kind of use and rollout of that toolkit and best practice, so that we can see less of a variation between the discharge processes that exist around supporting carers in that discharge process.
Thank you very much, Jane. We'll ask Neil to respond in a moment to those comments, but 2 final interventions, one from Claire Riley, Executive Director of Corporate Governance, Communications and Involvement. Claire.
Thanks, Chair. Just to add to Jane's comments, some of the work that we're working with Von on is to actually articulate some of the best practice that happens across the region, both at a place space, at an area level, and also at a regional level, with regards to the voluntary sector and community sector and the outcomes that is generating, and really looking at taking the learning from the learning event last week to see actually how can we spread and share that best practice so that we also learn from each other too. So there's a lot of work happening around this, and hopefully that will then inform the broader impact and the hopeful adoption of best practice across the region. Thank you very much, Claire. David Purdue, Executive Chief Nurse.
Just a response to Hannah's question really was around the work that we're doing with the Children and Young People's Strategy and the separate core 20+5 to tackle health inequalities, looking at much wider determinants of health. And actually we have got much more freedom in terms of that agenda that's not as set in stone as kind of the one for adults. So just some of the work that we're doing around starting very early to try and influence kind of future health requirements.
Thank you very much indeed. Neil?
Yes, so a couple of specifics on community pharmacy. Yes, we are engaging community pharmacy in extending minor ailment scheme, and actually we're one of the first areas to roll out a pilot for treatment of uncomplicated urinary tract infections, which is hugely successful and has diverted thousands of individuals away from primary care. So more of that is what we need to think about. Variation in the implementation of the PCN does, yes, we need to pick that up, and we will we'll certainly look at that. But my reflection is that all of the comments gets to the purpose of why we are here as an ICB, and I think that is coordination. It's we've talked about system leadership, learning, making connections, considering the wider determinants. I think it gets to our purpose, so I welcome all the comments.
Yeah, and I've used the phrase in previous meetings that we are a system of systems, and I think we've just been discussing one of our most important systems, and there are things about it where we need to understand it better, improve it, and see what's happening elsewhere. So thank you, Neil, for taking us through that very interesting discussion. Thank you. If we move on now, the next item is David Purdue's, and this arises because of a failure in standards of maternity care in one part of the country that was subject to a very rigorous investigation and public-facing report. And as a result of that, nationally, all parts of the NHS were asked to review their situation against the standards and recommendations of that report. So David, and this is very much work in progress, I think, but David's going to tell us how we've approached it and where we've got to.
Thank you very much, Chair. So as you said, Donna Ockenden was commissioned by the former Secretary of State to look into the failings for newborn, infant and maternal harm at Shrewsbury and Telford Hospital, and hence the Ockenden report was initially published in December 2020 and with the final report in March 2022. So all trusts with maternity services were required to submit evidence for all the 49 questions within the first 7 immediate essential actions, both on them workforce and guidelines. So this was analysed initially by the regional maternity team and reports released in December, and then they were re-reviewed in August of this year. So the final Ockenden report identified another 16 immediate actions, but that has been delayed in terms of our response to that while we wait for the East Kent report, which was due to be published in September and now has been put back to later in October. So in terms of where we are, in terms of the analysing from December to August, we can see a rapid improvement in terms of where our individual organisations stand. So we have 8 providers of maternity services. So in the table, you'll see where they are against kind of the 7 immediate and essential actions, and then the 49 responses towards that. There are 3 organisations in the patch who are compliant with all 7. They are North Cumbria Integrated Care, South Tees and Northumbria Healthcare. Just in terms of the 2 key areas, one is around informed consent and the other is around risk assessment throughout pregnancy. We will be the first ICS in the country to have the same digital platform for all of our maternity providers and having an end-to-end maternity system, which is excellent news and actually makes the evidence base much easier to collect. So in terms of those 2 areas, they're the ones that we are working with, and it is essential in terms of the Maternity Voices partnership that we work really closely with our MVPs to get to a point where we are compliant with all. I think just to say that workforce remains amber for all providers, which is a national issue, and so work's been undertaken with the regional workforce team to review training numbers with our higher educational institutions, and looking at a short and postgraduate midwifery course is being discussed with HEE. So we do have some recruitment of international midwives is underway in a number of trusts, but the pipeline for international midwives is not as strong as other registrants due to the training undertaken outside the United Kingdom. And the places that have international midwives that have trained overseas, there's at least a year's lag in terms of their ability to work independently. So in terms of those key themes, they are the 2 that we are really focused on, and just happy to take any questions from the report.
Okay, questions and comments on this? Hannah, Hannah Bowes, Independent Non-Executive Director.
Thank you for that. One of my questions was around, so most of what covered in this really helpful report is around how we're performing across the different sites. What I'm interested in is the differential patient experience. So we know nationally, for example, that black women and those from other BME backgrounds are more likely to have adverse or poor outcomes in their maternal pathways, and ultimately are disproportionately represented in the groups that are affected by serious incidents or neonatal maternal death. I just wondered whether we are seeing those kind of patterns here and how that factors into some of the work that's been done. Thank you.
So that's in a national report, and obviously statistics are quite shocking in terms of women from BAME backgrounds. So in terms of what we're doing across, we do have really strong partnerships with Maternity Voices partnerships, and looking at kind of those groups to be as effective as possible in terms of raising concerns. So in terms of the statistics in this patch, I'll send those to you in terms of where we are. But the really important thing is showing that good practice and getting that co-production working properly in terms of what we need to do to improve. So one of the key issues around that, which is very workforce dependent, and obviously a letter came to all providers last week from Jackie Dunkley-Bent, who's the chief midwife, and from Ruth May, was around continuity of carer. So one of the core 20+5s, continuity of carer, is based on the women who are most affected, so both BAME women and those in the most deprived areas, that continuity of carer will still exist for those group, which means a different model of delivery of maternity services, but the remainder of continuity of care has been stopped for now. But that is the best way in terms of ensuring that you have a seamless transition. You see the same midwife all the way through your antenatal period, your delivery, and kind of postnatal.
You want to come back on that, Hannah? No. Thank you. Sam, just hold on. I'll just take David Thompson from Healthwatch.
Thank you. Thank you for the report. And a specific question which I would like to ask is mentioned at the bottom of page 6. It mentions continue to learn from women birthing people. Might I ask to what extent you have been able to do that meaningfully, and have there been any worthwhile suggestions from patients, lessons to learn which you would use to improve the service?
I think all of, I suppose, the Ockenden report itself is taken from the experience of families and women, and the way we do that is through kind of Maternity Voices partnership. And that strong work together. So in terms of improvements, I would say kind of all the improvements from Ockenden are from the women who were affected by the service. So it is very much kind of from the perspective of the individuals, both the women and then obviously the children. I think the big thing around the second Ockenden report is much more focused around neonatal care as well as maternity care. So obviously what we've done from an ICB is that now I'm the Senior Responsible Officer for the local midwifery and neonatal delivery network, and we're working very closely with the clinical delivery network and the neonatal ODN to actually coalesce all the work that's been undertaken, so we do share learning across the system.
Tom Hall, Local Authority Partner Member and Director of Public Health.
Yeah, thank you for the report, David. It's really helpful to see it all kind of condensed into one place, which I think is really useful. It actually links back to kind of Neil's report as well, and thinking about the role of the ICB in terms of helping support learning, development, kind of rapid rollout, those sort of things. But also I think one of the key things we should be asking our system is how can we help? And are they the kind of, what if we were to ask that at this point in time, what are the sort of themes that would emerge and therefore give you a focus for some of the network's priorities?
So I think, yeah, so I think for me, kind of coming in into the system and looking how it works, I think there are a number of areas that we've got plans to develop. Some of that is around, obviously, that good antenatal care and ensuring that that's seamless. And part of that is getting into those hard-to-reach groups, because they are the ones who will not come to their appointments. And actually, a lot of this is taking care to individuals rather than centralising processes. So that's one of the key programmes of work we're doing at the moment. And then the other, I suppose, is around kind of that continuity and how we get that across all our different areas. So I think we've got some really high-performing areas, and it's how we learn. They're doing very well to ensure that that's in place for the other areas. And there's some really good work in terms of the right place of birth, and and the ICB leads the way to a certain extent in terms of the right place of birth, just because of how services have been commissioned. So you only have 2 level 3 units, all the rest are level 1, so we haven't got the ambiguity of level 2 units. So actually women do get to the right place to give birth, and that's a really good example of how this ICS is working really well.
Thank you. Eileen Kaner, who's in... I'm sorry, you had a flag up at one stage, Eileen? No? No, okay, it's the problem with the water bottles again. Sam Allen, Chief Executive.
Thank you, Chair. Just a couple of questions, really. I mean, firstly, I'm really pleased Hannah picked up the point around the sort of differential experiences, but also the patient voice, because thinking about Donna Ockendon's work, it's often gone to places and organisations where perhaps experiences are being described, but perhaps people weren't being listened to. So I think having the maternity voices really working in the network is really positive, because I think as well as prevention, in terms of our overview of this, it's trying to prevent scenarios where perhaps we might have a similar situation somewhere on our patch. So any further reflections you've got on that, David? But secondly, our NHS Foundation Trust Provider Collaborative, obviously the thing they all share is they all deliver maternity services. So I'm really interested in how they are working together on this to learn, to share resources, and the 3 organisations who are agreeing across the board. Are we seeing standardised practice, procedures, and greater collaboration?
So in terms of that partnership, in terms of the Maternity Voices partnership, we've welcomed onto the LMNS 2 new partners at our meeting we had only 2 weeks ago. One of those from a BAME background, which was really excellent in terms of them sharing their experiences and getting and us listening really effectively to that. I think in terms of the work jointly with the regional midwifery team, so we're meeting them this week just to go through kind of how we assess where people are effectively, and actually some outcome measures that we can agree jointly to get people all to the same level. We do have differentiations in terms of maternity services, because obviously we have some tertiary providers, and looking at kind of how they need to work more effectively with their partners in terms of some of the pathways between the tertiary centre and then the non-tertiary centres. And in terms of sharing good practice and getting everybody to the same level, that's something that I think the framework that we're looking at in terms of those outcome measures will get a better understanding of that. We obviously got one organisation which is in the National Maternity Improvement Programme, and we have a second one joining, and potentially a third one will join after that. But I think that's how we make that more regional than national, so it's actually helpful and beneficial, and that we co-align what we are doing from an ICB to what the Maternity Improvement Programme is doing.
Thank you. Graham Evans, Chief Digital and Information Officer.
Thank you, Chair. Just in response to the Chief Exec's question about learning, the reason that we've adopted a common digital platform across the region was because a small number of our trusts were already using this particular technology, and in the spirit of learning and spreading that knowledge, that was one of the main sort of drivers. Longer term, having a common information system will lend itself to the learning culture that we're adopting, and also using that data in a rich form to inform research longer term, and that's one of the key benefits of working together as a system. Thank you.
Thank you. I've got just a point to make, which is a generic point, I think, which illustrates from this example a gap in the ICB role at the moment, and that's, what in public health terms would be called surveillance, which essentially, in the future, a situation like this, whatever service it's in, we would like to have known about it, spotted it early, and done something about it. Yet our data our systems of data are not yet shaped to allow us to do that in all areas of service. So I just wondered, David, you must have given this some thought and thought, well, yeah, because you basically had to do a largely special data gathering exercise in order to answer the question, where do we stand on maternity services quality and safety? And ideally, you should be able to call up a surveillance report on that quite easily. Now, obviously, that's slightly idealistic because we know that we don't yet have systems of data that can do that. But I just want any thought on that, and maybe Graham would like to say something as well, or Sam.
Yeah, thanks, Chair. I think the important bit is that all trusts who provide maternity service should now have a report that goes to their boards, which looks at actually where they are with Ockenden, where they are with CNST, which is a clinical negligence scheme for trusts, specifically for maternity services, and also the use of the perinatal review mortality tool. So actually we should be able to see quite clearly in terms of that, what the information shared at board, we should get that quite clearly. Now that is done differently at the moment, and part of the work that we're going to do is to standardise that across, so we do have that complete understanding of where people are with their maternity services.
Yeah, and then I just think there's again an important principle in what you've said, in that whatever service it is, if we did have better surveillance, then there'd be a decision about what we should be leaving to the organisations and services themselves, and if you like, what sort of meta-analysis we should be having at the ICB level. But yeah, Graham, any thoughts?
Thank you, Chairman. So I think we are in an evolutionary phase. I think some of the data sets that we need to use in a surveillance manner are probably growing now. And as we start to mature as a system, understanding the questions to ask and then finding the right data will be something that we use as a board in terms of our intelligence. But I think it's still early days yet, and learning from Ockenden, gathering that data and becoming a bit more mature in our thought will certainly help going forward.
Thank you. Sam Allen, Chief Executive.
Thank you, Chair. I mean, I think this is multifaceted. I think the building the partnerships where we're bringing the community partners, people with lived experience, into the room with us is absolutely the heart of this, because the data will only tell us so much. It won't give us the enriched data around people's actual experience, and particularly where people have been on the receiving end of harm and how they determine harm. So I think the local, our maternity network, our partners in that, having the voices represented. I think your point though, Chair, around we're a system of systems. So one of the things Graham is doing, we're working together with the North East Commission support units around building what we've termed the flight deck, which is how we get real-time information. So the metrics Neil presented on urgent care, how we can get that in real time. So we've got a view of the system through the lens of the measures and the way in which the system is performance managed, but it is the triangulation of not just the lived experience of people who use services, their families, their carers, the communities, but also the workforce, the people that work in the service. And I think when boards are looking at maternity services, one of the key areas they're looking for is that connectivity between what they're reading and the data's telling them vis-a-vis what their workforce is telling them, as well as their patients coming through the service. So we're getting the view of the system, but it's how we triangulate it by making sure that we are as inclusive as possible in bringing people into the room through our clinical networks, and also through the way in which we work, which was why last week when we developed we had our inaugural learning improvement system event, it was really important we had patients in the room, we had people lived experience in the room, that we're co-producing this.
Thanks, Sam. Tom, you got your flag left over, or you've got another
no,
point?
it's a new flag now, Liam, just keep you on your toes. It was just to reiterate the importance of the child death overview process. It's a relatively narrow view in the scope of the whole Ockenden report, but it's a really insightful process that we need to make sure is being built into our learning as we move the maternity systems forward.
Well, another very interesting discussion, and this will be something that will be coming back. For now, David, thank you very much for giving us that progress report and telling us about the work that's going on. And I think you're staying on your feet now for the next item, which is on safeguarding and learning from life and death reviews for people. Oh, we've got a break. Sorry, it's been pointed out to me. Actually, we should stop and have our 10-minute break. So back in 10 minutes. Thank you. We're resuming the second meeting of the Integrated Care Board for North East and North Cumbria, and after a short break, and we have item 15 on the agenda, which is safeguarding and learning from life and death reviews of people with learning disabilities and autistic people. It's a position paper, and introducing it, David Purdue, Executive Chief Nurse.
Thank you, Chair. So in terms of safeguarding, the integrated care system has the statutory responsibility in health to be assured those processes and procedures for safeguarding are robust and keep people safe. The existing safeguarding services remain in place while the strategy for safeguarding in the ICB is developed. So the final structure is required in the first week of December, and as part of the initial process, a self-assessment and heat map was submitted for review by NHSE on the 9th of September. So in terms of our current position, our ICB, as we've rated ourselves as amber, and for our multi-agency safeguarding hubs have all been rated as green. So safeguarding is my responsibility in health for the ICB. And within the ICS, there are 13 community safety partnerships, 10 adult safeguarding boards, 11 children's safeguarding boards, and 13 multi-agency safeguarding hubs, and 1 violence reduction unit. So in terms of the 2 amber areas, there we need further work. One is around the revised Safeguarding Accountability and Assurance Framework, which was published by NHSE in July of 2022. And the purpose of that document is to set out clear the safeguarding roles and responsibilities of all individuals working in providers of NHS-funded care settings and NHS commissioning organisations. So in terms of our next steps, so in order to inform and continually develop the North East North Cumbria ICB safeguarding arrangements, including the operational plan on behalf of the executive, on behalf of myself and safeguarding professionals, we'll establish a safeguarding exec committee reporting to the ICB Quality and Safety Committee. We'll lead the NHSE and our North East North Cumbria designated forum for the purpose of ensuring safeguarding expertise is available to ICB commissioners. So the development of a joint forward plan to ensure it's inclusive and does not carry quality or safeguarding risks. To design and coordinate the operational safeguarding plan leading from 2022 into 2023-24. Lead and design the safeguarding strategy aligned to all ICB and HSE priorities for safeguarding, and then work closely with ICB as well as regional and HSE colleagues to align our work and share good practice and learning. And the final strategy will be delivered in December. We're happy to take any questions on that element of the paper.
Thank you, David. Questions and comments on this report? Again, it's a system within our system which needs to be got right and functioning well, and the report clearly is another example of where we've inherited a function from the clinical commissioning groups. We're reviewing it, getting to grips with it, and setting improved arrangements in place. So it is work in progress. But at this stage, any views to help David in performing this role would be very helpful. Eileen Kaner, Independent Non-Executive Director and Chair of the Quality Subcommittee of the Board.
Thank you, David, for the report there. It was just a comment, really. I'm not sure that all of our local authority partners are here today at this board, and safeguarding clearly is an issue in social care and for local authorities. A lot of the report there was wonderful, slightly NHS focused, and we just need to make sure that we have social care and local authority safeguarding on our radar.
Anything you want to say there, David? Have you, I mean, presumably you've had quite extensive discussion with the local authority directors?
Absolutely. I mean, there are 3, obviously, statutory partners within safeguarding health, which is now falls from previous CCGs to the ICB, local authorities, and then the police. So we're the 3 statutory partners. I suppose this paper is just is identifying kind of where we currently are from a health perspective. That doesn't stop at the work that's happening within those 3 statutory partners.
And Raj Nadaki, Nadakani, the Foundation Trust Partner Member.
Yeah, thanks, Chair. I didn't know, David, whether you were going to take Appendix 2 about the learning.
Yeah.
Okay, so the question is, sorry, I didn't know whether it was in this section. I'll come back on that one.
Okay, thank you very much indeed. Nicola Bailey?
Yeah, and I think it links to David's point about the partnership at place. So both for Dave Gallagher and myself, in terms of our roles, a key part of that is about working with the local authorities and ensuring that our responsibilities through the Directors of Nursing and ourselves are there in terms of safeguarding, that we're clear what our responsibilities are, we're clear what we need to do. And it's not just about the end of the safeguarding journey, but it's actually that early intervention, prevention, and the work that we're doing around child poverty and supporting families early is really important in terms of understanding that safeguarding journey. So there is a real need to be connected on that. And I think just to reassure Eileen, both historically as CCGs and now as the ICB, we are absolutely kind of in the same room with our local authority and police colleagues on this.
Okay, thank you very much. I don't see any other requests to speak, so we'll move on to the... Thank you very much, David, for that, and we look forward to keep...
Just going to do the leader element.
Sorry?
I'm just going to do the leader element, if that's okay.
Yes,
okay,
yes.
So leader is learning from lives and deaths of people with learning disabilities and autistic people. And this again is a position paper. So the North East and North Cumbria were the first region in England to implement the leader policy in 2016. And so much has been improved as a result of that. But the national report this year still showed that on average men die 22 years younger if they have a learning disability than without, and women with a learning disability die on average 26 years sooner than women without a learning disability. So this work is vitally important in terms of taking this agenda forward. So in terms of where we are from the North East and North Cumbria system, we will fulfil our leader responsibilities, ensuring the core values and principles are set out in the policy, as well as those developed by the North East North Cumbria Stop People Dying Too Young Confirm and Challenge group, who are central to our delivery. So there are some considerable underreporting of deaths from black and minority ethnic communities. And so in terms of the ICS, we will adopt a named individual who will be responsible for ensuring the challenges faced by people from black and minority ethnic communities are well understood, considered and addressed as part of our leader programme. We'll also, in terms of governance, we have set up the ICS Leader Governance Board, is established and chaired by myself, and the terms of reference have been developed and set out mentorship, responsibility and accountability. And again, this is really vitally important that on that committee we do have people with a lived experience of learning disabilities. So in terms of our governance board, the ICP leader panels will be established and functioning by December 2022. And the biggest important part is obviously learning to action. So fundamental purpose of our leader is to learn from the lives and deaths of people with learning disability and autistic people. Learning from the reviews needs to be widely understood at the 13 places at ICP and then at ICS level. So at ICS, learning to action should be led and overseen by myself, and it's coordinated by the ICS Leader Governance Board through the Learning Disability Network. So each place will have an ICB panel, and ICS Governance Board will have its own learning to action plan, comprising of a description of improvement actions needed, who will carry it out, how and when. And this will be done and monitoring assurance arrangements that demonstrate successful completion. And as part of this, they have a regular slot in terms of leader, and learning will be at the system quality group, and every 2 months there'll be a full undertaking of actions required and how we improve care for people with a learning disability and autistic people.
Thank you. So comments and questions on the second part of David's report. John Rush, Independent Non-Executive Director of the Board.
Just a quick one, David. Just in terms of one of the paragraphs there, talks about that they have a meaningful engagement and co-production with people. and they established the Stop People on Learning Disability Dying Too Soon Confirm and Challenge Group. Is that right across the whole of the geography? Because I'm conscious, probably to do with my background from North Cumbria, I'm conscious sometimes that things that are said we've established are sometimes just northeasterly based rather than northeast and North Cumbria.
No, and actually Cumbria's got its own Confirm and Challenge group, which feeds into the governance board.
Okay, thank you.
And I have to say, the work of that group is fundamental, and they do some fantastic work in terms of ensuring that we do have all our documentation is obviously in a way that people with a learning disability completely understand it.
Thank you.
And produced by them themselves.
Thank you.
Raj, you want to come in again on this one?
Thank you, Chair, and thanks, David. Clearly, a lot of work going on, and it's a really good summary. The question I had was, it seems like not just the leader learning, but also the learning disability group, which is doing work. There's lots going on.
Yep.
And then there is work going on with the elective work on waiting well and inequality, score 20+5. I think the Chair mentioned before, is there a plan to get this together and see what is going to be truly transformative amongst all the stuff which is going on, or what is going to be incremental? Because we can't really go on with the real gap we had with people who die, you know, about 20 odd years earlier than the rest. So any thoughts on that?
Yes, I think there's a number of things that we're looking at trusts. Obviously, one of them in terms of waiting lists. There are some trusts that have put anybody who's got an identified learning disability has gone to the top of their waiting list, irrespective of kind of what priority they are. And we have to share that good practice across the board. So I think that's a fundamental part of this work. But I do think it's much more around the people with a learned experience, how we utilise those. And I have to say, kind of at the first governance board that we had, they had a fantastic, strong approach to how they wanted this to work. Some of that will be transformational, but actually it's embedding it across the ICB, which is really important.
David Thompson. Sorry, Nicola, you're sharing a...
Yeah, but,
Nicola Bailey.
I think it's just to add to David's point. I think we've got an incredible resource with the Stop People Dying Too Young group that we need to make sure are centre stage in everything that we do. But I think when you look at Leader and then you start to think about the kind of population and health management, you start to think about annual health checks, you start to think about screening, you think about disadvantage and COVID, then there are a lot of lessons that I think we need to learn. Some of those are very basic, which are about reasonable adjustments and ensuring people do and can access annual health checks, and some of those are much more deeply embedded, I think, around sometimes diagnostic overshadowing, sometimes around lack of screening because people don't necessarily understand why they need to go, and also linked to safeguarding, sometimes the number of people that do not attend appointments or are not brought to appointments, and there is a bit of a distinction there sometimes depending on who they are. So I think there's lots of information that we can triangulate to start to look at what are the things we need to do across the system to enable us to learn better. And I think the other thing that we need to do as an ICS is we need to develop an autism statement, and that's something that we're beginning to do some work on, and we've got a kind of an early draft of that working across local government, ourselves, community and voluntary sector, experts by experience as well. So that's something, again, that we would want to make sure the kind of focus on improved health and well-being is a key part of that.
Well, thank you for those comments, and thank you, David, for the presentations, and we look forward to keeping in touch with what's happening on that important area. Thank you very much indeed. We're back to you, Neil, now. The Vaccination Plan. Okay. Neil O'Brien, Executive Medical Director.
Thank you, Chair. So you have in your pack a paper which just summarises the vaccination activity that we've been engaged in 21-22, and then maybe a future look going forward. But I'm not going to go through everything in the paper, but I just wanted to pick out a few salient points. Firstly, on flu, deliveries of the flu vaccine for this season are arriving, and we have an aspiration to try and certainly hit the flu coverage that we that we did last year, which was exceptionally high, actually. I think the focus on immunisation around COVID certainly helped people come forward for their flu vaccination. So we want to try and match that performance. What we do know is that last winter, the amount of circulating flu, because of social distancing, mask wearing, was pretty much non-existent in the UK. If we take learning from the Southern Hemisphere, in July, there was quite a wave of flu that affected the Australian population, and that can often correlate with what we will see for our winter. There is the potential, obviously, for a wave of flu along with COVID, which could put significant strain on our health services, which is why our immunisation programmes this year are of paramount importance. I've put detailed in the paper the groups that are eligible for flu and our aspirational targets for those. And then on the COVID vaccination, we have agreed to extend our coordinating function with our arrangement with Newcastle hospitals to try and help with the coordination up until January, where the vast majority of COVID vaccinations should have been given in that time. To date, it's worth noting that nearly 7 million COVID vaccinations have been given in the North East and North Cumbria, and a 250,000 spring boosters. And we've certainly got capacity in our networks of 71 PCNs, 130 community pharmacies, 19 hospital hubs, 15 roving services, and our vaccinations, mass vaccination centres to offer that capacity to the public. So offers for COVID vaccinations have already started coming through. In fact, I just had my text just about 10 minutes ago to make my appointment. So work is definitely underway. We're going to try and co-administer COVID and flu vaccines wherever practically possible. But there are some logistical issues around why that might not be possible at all times. So there's a chart in there on the key milestones of the campaign launch, which we are halfway up the chart there, where first appointment slots are being made available. I get daily updates on our uptake, and I think as of yesterday, we've done about 40% of our most vulnerable, which are care home residents. I just wanted to very briefly mention monkeypox. This is a vaccination programme that is being led by the UK Health Security Agency, or UCSA, but we have a role, I think, in helping the system roll out this vaccination programme, and we have linked them into our vaccination infrastructure to try and assist with this. There were some supply issues of the vaccine early on, but this is now being resolved, and we are steadily seeing the number of vaccinated individuals increasing, and the number of monkeypox in the North East, active cases, doesn't cause too much for concern at this time. There's a section on there on other vaccinations, which is the whole scope of vaccinations that's currently overseen by NHS England. Now, the ICS's role in vaccination is slightly unusual in that we don't directly commission it. It is directly commissioned by NHS England, but again, this goes back to our role and purpose of having that coordinating, that joining, that function of joining the system together, which is where I think we have real skill. We've done this through, again, a vaccination board across the ICB, and then well-resourced and well-supported local place-based vaccination boards. Now, the reason I mention other vaccinations, a couple of reasons, is that to show you that our performance is pretty good, and certainly in primary immunisations, we consistently perform at the top in the country, well above the 95%. We do have some issues around the second preschool boosters, around MMR, where the uptake slightly dips, and we're working with practices with NHS England to try and improve the uptake. The priorities around the other vaccinations are around improving uptake of the MMR preschool boosters, polio-containing vaccines, because we have seen nationally, internationally, some rise in the polio numbers, make sure that we've got that coverage. And as I say, we've got a work plan which tries to address some of this. We have excellent support from comms and engagement, both nationally and within the ICS, about getting the messages out around vaccination, and we've agreed our key messages for that. On future delivery, we think that the responsibility for the full vaccination programme will come to the ICB in 2024. Just to give the board reassurance, we absolutely understand the importance of this work and that there is sufficient capacity to support excellent coverage of our vaccinations going forward, which is why the Executive agreed the extension of the support from SFOC. We're currently looking at what additional support from the ICS will be required to continue our vaccination through next year and to start to incorporate the vaccination schedules of all of the primary immunisations, and we'll bring further updates on that later. But it's just to reiterate that we will ensure that there is sufficient support for all of our providers. There's a lot of, in my experience in managing the vaccination programme, is that it's logistical issues around getting vaccine supply to the right place. And if we've got, as I've mentioned, many individual providers, it's very difficult for them to do that themselves. So we have a key coordinating function that to ensure our population is well covered. So that's probably all I wanted to mention. I'm happy to take any questions on anything that I've mentioned.
Okay. Thank you, Neil. It's a subject we will be returning to, but you've given us an excellent situation report and a bit of a forward plan. We are getting very tight for time. I wondered if there were any essential points anyone wanted to raise at this stage. If there are any afterthoughts, don't hesitate to come back to us and to Neil in particular. So thank you very much for that. Item 17 is to be presented by Jacqueline Myers, who's the Executive Director of Strategy and System Oversight, and it's an integrated delivery update report with some slides, I think, to help your presentation.
Thank you, Chair. If I may, I'd just like to make some opening remarks about the report. This is the second one we've seen, as it's our second board meeting. And I just thought it'd be helpful to set it in context of some of the development work that's still going on in the ICB. So we're in the process of developing a comprehensive oversight framework that responds to the National Oversight Framework that was published at the beginning of the summer. And through that process, we'll be developing a range of reports and oversight meetings and progress actions with all parts of the system. So that will address the way that we work with individual providers, also how we work with our place-based boards on the delivery of their plans, all sectors including primary care, as was mentioned earlier, and also how we'll provide oversight to our key strategic programmes and clinical networks, and then how that all comes together in the oversight report that you receive here at the board, this integrated delivery report. So as you receive the report today, it's just to be conscious that there's a lot of work going on to try and give us that clear and comprehensive review of each part of the system and how it's contributing to the delivery of our goals and objectives. The second thing I wanted to mention, Chair, was just the ongoing development of our integrated care strategy, something that most of us were present for a discussion on at the Integrated Care Partnership last week. And clearly, as that process concludes, that will shape elements of this report that you receive, and because you'll see a clear alignment between the objectives and goals we set in the strategy and the subsequent detailed 5-year plan, and the things that we're measuring here in the integrated report. And I think in particular we'll see a strengthening of the section of the report that looks on delivery of local priorities within the area ICPs, where I think we've got quite a bland report before you today, a kind of sea of amber. Through the medium of developing the detailed 5-year plan, we'll have much more granular and measurable milestones in those plans, and therefore you'll be able to see much more clearly whether we're progressing effectively in terms of delivery. In conversation with yourself, Chair, I'm not going to attempt to present each slide in detail, as this is an extremely comprehensive and detailed report. So I'm just going to make a couple of very high-level remarks. I've then, rather than having the whole slides up on the presentation board, I'm just going to draw some points of interest out and then hopefully leave space for any questions at the end. So at the front of the report, you've got key points there, and some of these have been covered already in the meeting this morning, so I shan't labour them. But it is important to note a couple of issues. We can see from the health inequalities slide that we do continue to have significant variation in terms of those health inequalities and some worsening of the position. And clearly that will be a key area of focus for our strategy as we land that at the end of the year. A&E performance continues to be a significant area of concern and pressure with volatile levels of activity. We still continue to exceed the average performance across England with a better performance here in North East and North Cumbria, but it remains a matter of concern. An ambulance handover times also continue to be a matter of concern, and I'll draw out a bit of data about those shortly. I'm going to look at referral to treatment times in a bit more detail, although we continue to see progress in relation to the very longest waiters, which are those waiting over 2 years. We're starting to see some concern further down the waiting list. Also I'd like to just draw out some points from the cancer slide where in recent months and in the time covered by this report up to the end of August, we are seeing some deterioration in the numbers of patients who are waiting over 62 days, which is clearly of significant concern. So just to add to the information that's provided on the slide, since the pack was pulled together, we have as an ICB initiated some interventions in relation to those very long waits for patients who are on the urgent suspected cancer pathway. We've got focus meetings going on with 3 providers where we've got the greatest concern. I'm pleased to say that in relation to one of those providers where we started some weeks ago, that's North Cumbria Integrated Care Trust, we have seen some real significant progress in the number of patients who are waiting there, and I hope that in the coming weeks we'll see similar progress in the areas that we're focusing on, because obviously we'd be very concerned to see any further deterioration in the number of people who are waiting over 62 days to get a diagnosis and or treatment. Okay, so I'm going to turn to the slides now, Chair, if I may. Gosh, you can't see that, so I hope you've got it in your pack, but I just wanted to draw attention to our quest to bring better insight to the data we share through use of statistical process control charts and analysis thereof. So if you get a chance to look at this slide, perhaps over a cup of tea outside the meeting, you can see how we're trying to bring some deeper understanding to the data we're sharing with you, both in terms of what's happening in terms of variation and what's happening in terms of whether we're seeing improvement or deterioration in the trend, and indeed whether the process is in control or whether it's volatile, so what level of assurance we can take that a target will be met either consistently or not. So just thought I'd draw attention to that. In terms of a couple of areas that I wanted to draw out because they're points of interest, actually I think this is apposite for the maternity discussion. Maternity is one of the sets of data represented here. This is a type of surveillance data, I think, in that we get friends and family. So this is patients and users of services rating the quality of service, and these data are collected extensively and then collated up to give a monthly percentage of patients that would recommend friends and family to use a variety of services. I've highlighted here some of the best performance, and I've done so in service of thinking about how we discharge that role as a learning system, identifying where we've got services that patients and are very happy with and keen to recommend, and perhaps matching them to some of our areas where we've got lower performance. And so if we look at the 4th column along, which is the maternity, we can see that patients are most satisfied with the services in Northumbria and in Newcastle University teaching hospitals. And if you look down at the bottom, we have least satisfaction in South Tyneside and Sunderland. And I know at the previous board meeting we talked about some of the work that's going on in that service. So this might be one of the data sets that we're able to use as a kind of early warning sign that we need to look more deeply into services to see what's going on. This is something that's part of the People Promise. It comes from the annually collected staff survey, and it asks members of staff whether they feel they're always having opportunities to learn. And I'm drawing out a couple of things here. You can see that Northumbria is an outstanding outlier, both in terms of its difference to the peer median and its difference to the national median. So clearly something for us to learn from that organisation about how they're engaging their staff in learning and developing. I'm smiling at my Chief People Officer colleague, who obviously has got experience in that organisation. Also, similar positive performance in Cumbria, Northumberland, Tyne and Wear Foundation Trust. And then I also wanted to draw out the data in relation to the North East Ambulance Service. Interesting that if you look at their difference to the national median, you see it's really quite concerning, almost 20% below the national median, and yet in the peer group they're a positive performer. So I think that tells us that it's a sector, perhaps relating to some of the comments that our Chief Exec made earlier, that perhaps struggles to get staff to recognise and embrace opportunity for change comparative to other sectors, so the perhaps opportunity to do some cross-sector learning, drawing from some of the best practice in our own patch. These are the data relating to the elective waiting times, the referral treatment standard, the 18-week standard. Just thought it was important to draw out what's going on here. In terms of the plans that we have in our patch and how we're doing, as I mentioned, in terms of the very longest waiters, we're slightly ahead of our own plan, and you've heard before that we have concerns in our complex spinal pathway in our tertiary centre in Newcastle. Those numbers are still falling, and they're still falling ahead of our own plan that we've set. But as you can see here, there is concern in terms of what's going on in the overall waiting list, which is still continuing to grow at a steady rate. And indeed, we've seen in the last couple of months that the overall, the waits for over a year, 52 weeks, are starting to grow. We don't have a national target to eliminate those by the end of the year, but we are expected to make progress and bring it down. I've put the England data underneath there so you can see this is a national trend as well as a local one. But I think what this is telling us is there's been really intensive work to manage the longest waits in the waiting list, but the overall list is under significant pressure. And just to add very briefly to what's shared in terms of information on the slide here, again, as an ICB, we've started to take action here. So we're engaging with the trusts, and we've just commissioned a piece of work to do a real in-depth analysis by specialty and by point of delivery, meaning outpatient, inpatient and day case, to see the relative waiting times by specialty in service of identifying opportunities to do what we call mutual aid. So can the organisations work together to address those longest waiters, focusing on the cohort who are either already or will be over 78 weeks or a year and a half by the end of March. So we'll be able to give further progress on that work at a future meeting. These are some data relating to urgent emergency care. I know we're tight for time, Chair, and we've had a long discussion about this topic already this morning, but I just thought this was interesting. Really concerning data in the bottom right-hand corner there. These are patients who are in A&E longer than 12 hours, really escalating, and in the summer too. And those who've studied these data over years will know that these things tend to peak in the winter. So really concerning there, and clearly a focus of all the work we're doing in urgent emergency care. On the bottom right-hand corner there, you've got the average hours lost to handover delays, and although those are not, it's not a good performance, and we know it's sort of 70 hours a day, it's not deteriorating. So it suggests that some of the work that was done over recent months to try and optimise handover within the context of the current pressures is having an impact. So some interesting insight there, but clearly a lot more work to do. And this is my final slide, Chair, just looking in relation to children and young people's mental health. I thought this was quite an interesting slide. Some positive news in the top left-hand corner that we are still seeing improvements, although they've slowed, rate of improvement in the number of children who are getting contact with community mental health services. The other interesting thing to show on this slide is that in the bottom left there, we have seen real progress, and we're ahead of plan in terms of the percentage of children who require urgent review being seen within 1 week. But we've got a corollary to that, which is that the routine waiting times have gone down. So it would suggest that we're not seeing, we haven't got sufficient capacity in the system. We've been prioritising the urgent children and young people, but as a result, routine waiting times have suffered. And it just gives an example of the pressure that the system is under, and the significant work that we need to do on expanding workforce and also finding new ways of delivering care if we're going to achieve both the urgent and the routine waiting times. That concludes the detailed stuff that I'm pulling out for interest, Chair, but I'm happy to take any questions on the main body of the report. Thank you.
Thank you very much, Jacqueline. Comments and questions for Jacqueline? Tom Hall.
Yep. Thanks, Jacqueline. Great report. Thanks for all the work that's gone into this. It's a huge amount of progress in a really short space of time. I know you've alluded to the fact that it's still a kind of a work in progress, so I hope you take my comments with that in mind, and building on the comments that I made at the last meeting as well around health inequality. So it's really great to see that section on health inequalities and how that features right at the top end of the report as well, which I think is really important. I suppose my follow-up point to that is that, yes, it's important that we look at things like gap in life expectancy, healthy life expectancy, child poverty, those kind of things, because they really are kind of key indicators of inequality within our region. But I think what's really important for us to look at as an ICB is inequality in terms of our performance and outcomes as well, particularly when we're thinking about the core 20 population, the 20% most deprived. How, if we were to cut our data around referral to treatment or 62-day waits, for example, by inequalities, how different would that look and what would that tell us? It's probably quite a technical challenge, but not insurmountable, but something that I'd propose we start looking at, but I'm happy to take views from others as well, and your feedback, of course.
Thank you very much. I don't know whether you want to make a response now or we'll gather together a few comments.
Well, I'll just say briefly, thank you for that, Tom, and I know we're going to meet outside the meeting to talk about the report, but we are intending to bring some data in relation to waiting times and indicators of multiple deprivation to the next board meeting, so you'll have a chance to see the first cut of that next time. Thanks.
Thank you. Annie Laverty.
Just a response, Jacqueline, to a great report and an ongoing ambition, I think, to enhance it and iterate going forward. I think it links to the opportunity around having greater surveillance and particularly learning from integrating staff and patient experience measurement in a meaningful way. So some of the organisations in the region that are leading not only regionally but nationally in this area, it's around learning and investment that has been a decade plus in the making, and I think we've got a real opportunity as an ICB from a surveillance point of view to be creative around how we integrate that measurement in a meaningful way. It applies to our maternity services, it applies to anything, and with greater number, having the opportunity to analyse within that data the experience of people from protected characteristics, represented from protected characteristics, or indeed your point, Tom, around health inequalities, and we would be afforded that. So I think really exciting opportunities to do that and learn from actually what is a wealth of experience in the region that exists to build on.
Hannah Bowes, Independent Non-Executive Director.
Thank you. Yeah, just a request really that in looking at some of that granular data, that people that live outside of the community, so in institution or in temporary accommodation, including things like prisons, but also those that might be in hostels or other types of non-stable or non-permanent or institutional settings are also included, because I think they are often not captured in some of the sort of headline data that we receive about people that are in the community, and obviously those needs may be different, they may be greater, but for what, you know, it's important for us to be able to understand that as well. Thank you.
Jacqueline, go ahead.
Yeah, no, I mean, really helpful comments both from Annie and Hannah, and indeed from Tom. I think there's a wealth of work that we can do that sits below this top-line report that can really give us insight and support delivery. And it's my intention that all of that gets done in collaboration with the kind of lead execs and the experts that we've got in the wider system. And I'm keen actually not to tinker with the report in an incremental way, but do something significant on the back of landing the strategy, so that coming back to your point about what we measure in relation to health inequalities, we've got an expert group developing our approach to population health, better outcomes and fair outcomes, and we will sort of remake our reports in light of what we settle should be our action in that regard. I think in relation to Hannah's point, that's an under-resourced and under-attended area of work, and it's something we'll have to take away and have a think about how we can do something meaningful in relation to that, but I'm certainly up for the challenge. Thank you.
Thank you. David Thompson, Health Watch.
Thank you, and thank you for an astonishingly comprehensive report. But two questions, if I may. Where there are recurring themes of concern, such as the ambulance response times, might it be worthwhile considering providing a more forensic report on that specific issue, particularly where there may well be risk to patients? And the second question, I may have missed something, and apologies if I have, but are there any plans to increase reporting on aspects of social care? Difficult though that may be and will be. Thank you.
Thanks, Chair. So on the first point, I think I'd be advised by the board, I guess, about the degree to which you want to have that sort of deep dive analysis. Do try and represent where work's going on in relation to areas of particular concern. There's obviously a balance of how deeply you go versus having that comprehensive review. I think also, as we start to feed these reports through to the board committees, there will be an opportunity to discuss these issues such as ambulance handover delays and that are linked to patient harm in those committees where we might have a bit more space, and then we might see things coming up to board escalated by committee chairs. But I'm happy to provide either a complementary report on a particular key area as the board requests. On social care, it is an area where we do need to develop further data sources, and we're working with colleagues in the local authority to identify data sources we can pull through. That's at a very early stage, but it is certainly our aspiration to include that in our report in the future.
Thank you. Sam Allen, Chief Executive.
Thank you, Chair. I'm conscious of time, so I'll be very quick. I just wanted to make the link between the variation and the increase in the number of 12-hour breaches in the emergency department to what we can see as an increasing length of stay for patients in hospital, and the conversation we had earlier, hence all of our focus around really supporting and enabling discharge as well as admission avoidance schemes as well. And then just secondly, I thought the GP patient experience survey again was just important to mention really. So whilst within that there is some good news in the North East, North Cumbria, we do have a downward trend moving backwards, and I think where we looked at the focus around the government's plan around the ABCD, particularly looking at primary care access, if we just look at the indicator around, the percentage of people reporting overall experience of making an appointment as positive, 59%. It was 73% in 2021 and 68% in 2020, but still slightly better than the national average of 56%. But it does really highlight the work we've got to do over forthcoming weeks and months.
Thanks, Sam, and thank you very much, Jacqueline. A lot of interest in what you're doing there, so we look forward to hearing more and seeing more of the analyses that you're producing. So thank you very much indeed. I'm speeding things up a little bit because we are getting a little bit tight for time with some items still to come which you need to know about. So we turn next to item 18. Which is the roadmap to place-based working, and we're going to hear from the two executive directors of place-based delivery, Nicola Bailey and Dave Gallagher. Okay. Dave first.
Thank you, Chair. So I'll kick off. I'm very conscious of the time. I'm not going to go through the report in detail. Probably just a reflection before we start. We've talked a lot this morning about systems and systems within systems, and one of the fundamental building blocks of our system is what we're calling place. So for everybody's clarity, place is the footprint of the upper tier local authorities, the 13, soon to become 14 of them, that we've got in North East and North Cumbria. The title of this suggests that there's nothing there at the moment, which is probably misleading. We've just had conversations about safeguarding, we've had conversations about A&E delivery boards. There's a whole plethora of things that happen around places, we're calling it. What this does is actually outline a roadmap to us as an ICB, clarifying with partners at place how we'll work with them and to make sure that the governance arrangements we have with them are fit for purpose and robust enough to start to delegate more resource and more responsibility out to those places. So it builds upon two things, the work that's gone on previously, but also some work that brought colleagues together on the 24th of June where we had a conversation around the ambitions for place and that the 13 places trying to work towards what they're trying to do. And this suggests a roadmap whereby we'll work with our colleagues at place over the next few months, by the end of October will have their views on how they'd like to consider working. And two parts to that. One is the degree to which they'll work. So there are 3 examples here in national documents in terms of having a meeting just to get reflections from people, having a committee of the ICB, through to having a joint committee with the partners, and particularly the local authorities. So the roadmap suggests that we'll get some feedback from them by the end of October, working with Nick and myself. We'll then bring that back to the ICB. We'll agree how we take that forward with a view to them working in shadow form financial year, and then running live from the 1st of April next year. So brief outline of where it's going. We'll bring the detail back once we've got it. But Nick might want to add anything to it, or happy to take any questions, Chair.
Nothing to add, I think.
No, she's shaking her head, so we can move on. But we do take a great deal of interest in the place-based working, because it's at the heart of the work of the ICB. So we look forward to having a fuller report at a future meeting. So thank you very much indeed. Moving on then to the 2 finance items coming up now, item 19 and then item 20. And if I introduce David Chandler, he can, as Interim Director of Finance, the risk, yeah, okay, sorry, I've gone wrong again in that. So let's take the risk management strategy, which is Claire Riley's item.
Thanks, Chair. I will be very quick. I think the paper is self-explanatory. It talks about our approach for risk management. It has been approved by Executive Committee. I'm conscious that we're also having a conversation at our board development session around risk and our propensity for risk as a board. It is aligned to national policy, and I'm seeking approval for this paper.
Any points anyone wants to raise on that? Yes, please, David Stout, Chair of the Audit Committee.
Claire seems a really very good strategy. With regard to implementation, what's your timescale for getting COVID risk registered, board assurance framework, IT system, risk appetite, etc.?
So we are working on that now. So we should, we're working with the GGI to help and support us. We should have this all locked down, I'm thinking October, November time. From a system point of view, we've all actually agreed to align to one system across the whole of the region now, David. So that's in place now. But certainly within the next 2 months, we should have all of this locked down.
That's great, Chairman. Thank you.
Okay. No other comments? We will then move on to David Chandler's item. David, Interim Executive Director of Finance, with a finance update and overview report.
Okay, thank you, Chair. And I will assume that everybody's read the paper, but if you don't mind bearing with me, I'll pull out maybe four or five key points for the board. So first one is, this is the month 4 ICB and ICS update report, has been through to the most recent Finance Committee. So to remind everybody, we effectively are working to 4 main financial duties. And I'll just go through those each in turn so we can all be aware of those and where we stand against those targets or duties. So the first one is the ICB itself shouldn't spend more than its revenue allocation, which is just less than £6.5 billion per annum. Our current forecast outturn is in line with plan, and that's to have a planned surplus of £2.6 million at the end of the year, and we're on target to achieve that. If you look in Table 1, you'll see a little bit of detail in terms of variances. You'll notice that we're overspending on independent sector activity aligned to elective recovery, but you'll also see underspends in areas like prescribing and on reserves to offset some of those pressures in there. We do have risks in ERF, which is elective recovery funding, because it's national funding that comes to us almost on a sort of payment by results take basis to a degree. And we have risks around prescribing and packages of care, where, especially in packages of care, we are seeing an increase in both price and volume in packages of care. A lot of high-cost packages of care starting to come through. If I take us to the second duty, as an ICS, so if you think about bringing in also the foundation trusts, which we have 11 into the fold as well, we also have a duty to manage that to break even as a collective. The current plan you'll see in Table 2, which is very summarised, and there'll be more detail later, is that the providers, the FT providers, are predicting a forecast deficit of £2.6 million in line with plan. So if you take those 2.6s together, you get to a break-even position, and that's where we're aiming for at this moment in time. The FT providers, they are identifying risks on delivery of efficiency plans, recovery of elective fund income as well, but also agency risks as well. We are spending an awful lot of money across the patch, but also nationally on agency costs. So that's a second area of risk. Our third duty is on capital. We have a capital resource limit of £187 million. We're currently forecasting we'll breach that by £32 million. That is a planned breach, if I can use that expression. We submitted that to NHS England at the start. We are working with them to, one, look at the limit, but also look at our spending plans. So we hope by the end of the year that will narrow that gap and come more into alignment. Most of the expenditure on capital is spent in provider land and FT land, so we work closely with the provider collaborative in terms of achieving that duty. And the last one is our running cost limit. So we have a running cost budget which is basically aligned to the cost of running the ICB. The budget's £43 million. It reduces every year because it's never uplifted for inflation. It's reduced by about 33% over the last 10 years if you go back to CCG days. We're on track to deliver that this year, mainly because we have vacancies in the system. Next year will be more challenging for us as an organisation. And that will require careful management, but I'm sure we'll have plans in place to deliver that. And the last one, Chair, if you can bear with me, is the Better Care Fund. So I've included a short section on the Better Care Fund. For those of us who maybe aren't as au fait with the Better Care Fund, it is essence jointly agreed plans at place that David was referring to between the NHS and the local authority and sometimes other partners. And that purpose is to help people, enable them to stay at home and live independently longer. A key feature is often the pooling of aligning of budgets between the NHS and the local authority. Part of that is mandated, another part can be voluntary. And we have measures that we're expected to deliver. So a typical measure would be avoidable emergency admissions, which we've been talking about today. Those plans always get signed off at the Health and Wellbeing Board. But I thought it'd be helpful today in terms of following on for the paper on place-based working, just to share with the board the amount that is aligned to Better Care funds across the region. And you can see that by place in the paper. So they were the main points I wanted to bring out of the report for the board today, Chair, and I'm more than happy to take any questions.
Questions and comments? David Stout.
Yes.
Chair, independent. I'm making an announcement just for the public out there. Independent non-executive director and chair of our audit committee.
Thank you very much, Chairman. Thank you, David. That was very helpful. In addition to the risks that you outlined, of course, we now have inflation running at far higher level than was ever anticipated when the budgets were actually set. My concern, I suppose, David, is that those organisations in the economy who actually said they would deliver a surplus may actually start reneging on that when they actually find inflation running at a lot higher level than was originally forecast and they signed up to. When do you think we will know from them what the real position is?
Yeah, thank you for the question, David. So you're quite right that inflation is a significant concern for many providers in the health and care sector. I can provide you some assurance in that regard because in June, NHS England worked with the ICBs in terms of identifying or trying to identify the inflationary pressures that organisations felt they would incur through the year. That was done in June, so obviously it was at a point in time. And NHS England did identify £90 million of funding for our ICB. I think it was approximately £80 million of that went to FT providers who were identifying pressures you'd expect on maybe gas, bills and the like, you know, where they haven't got a contract, but also where maybe they've got a PFI contract which is linked to inflation. So in this regard, NHS we're really good in terms of working with areas to identify those pressures, verify them and provide funding to support that. There may be pressures on top of that, obviously, across other sectors or just within individual organisations. To be fair, I think most organisations at this moment in time would say to their biggest pressure from a cost point of view is probably on staffing and filling vacancies because of agency costs or bank costs. That's probably their biggest risk, but they have generally tried to factor that into their forecasts. But it is an increasing pressure as we go into winter.
Thank you very much, Chairman.
Thank you, David. Sam Allen, Chief Executive.
Thank you, Chair. David, my question's around Table 6, the Better Care Fund. What we've got in there is the annual contract value for 22-23, but no indication as to whether or not sort of how those contracts are performing in terms of anything under or over, really, in terms of the total contract value. But the sort of the main point is the additional funding that we're likely to get to support discharge from hospital, the sort of accountability for that funding. There's a role for us as an ICB in terms of perhaps certainly working with our local authority partners, but having oversight of that and ensuring that the money is actually achieving the outcomes. So how we link the financial performance to deliver of better outcomes. I guess it's the overall question, really, but obviously with a focus on Table 6.
Yeah, so Table 6, the management of the Better Care Funds happens in two ways. It'll happen within place in terms of managing those resources. The vast majority of them will be around out-of-hospital type budgets in terms of the community side of things. And as you can see, there's a wide variation of approach in that regard. So a lot of that management will happen at place, but then any variances will be incorporated within the overall report that we bring to the board and to the executive. At this moment in time, we're not identifying any significant pressures in those areas. Many of those budgets are block-type contracts. There are a few areas, if I take Sunderland, for example, Sunderland's a good example, where the prescribing budget is incorporated within there. That's actually underspending, but their packages budget will be overspending. And as you see, I sort of refer to those at a system level early on the report. So we do capture them, and they are managed at place. And it probably goes back to what David was talking before about developing those arrangements about how we work at place in terms of delegation of responsibility and then working as a system to manage that. So that hopefully answers your first question, Sam. The second one, in terms of how we will work with our local authority partners in terms of additional resources that we believe are coming our way from recent announcements. We haven't got as much detail yet as we would like about that, but it will be essential that we work collaboratively to hold each other to account on the best use of those resources. I think a lot of that will happen also at place as well, but not exclusively. So I think there's just a bit more work to do in that once we know a bit more of the detail about how that money is going to flow. Whether it's linked, for example, to the Better Care Fund or whether it's a separate item of expenditure. But clearly we want to make sure that collectively we get the biggest bang for our buck for those resources, especially coming to this difficult winter.
Thank you. Any other comments anyone wants to raise? Tom Hall.
Thanks, Liam. This might not be a question specifically for you, David. Others might want to chip in. My question, the issue of workforce has come up several times today, and we've talked about agency spend and coming agency caps as well. That's not just an issue that faces the NHS, but the wider health and care system as well. Are there any opportunities for us to think radically differently around how we support the workforce within region, perhaps looking at hosted agency models or something where the NHS takes a lead role in providing resilience in the system?
I could try and answer a little bit of it, but I'm probably not the best person to answer that completely. But what I can give you some assurance is that I know NHS directors of HR, but also the Director of Finances are now starting to come together and talk about how we can do some of those things that either we already do, but we can build on it and get more consistency as a patch. So we had a very similar conversation along those lines just last night with the Director of Finance. So there's definitely an appetite for that, to build on some of the things that we've already got. But that's a very finance part answer to the question. I suspect there's people better qualified than me to maybe answer some of the other parts of the question. Thanks.
Sam Mallon, Chief Executive.
Just say the short answer is absolutely yes. And I know Annie, our Chief People Officer, is getting our workforce board up and running, and I'm delighted that Pam Smith, who's the Chief Executive of Newcastle City Council, has agreed to chair that. So I think really bringing that opportunity, Tom, around the integration around health and care, but ultimately across North East, North Cumbria, we have a situation at the moment where we have variable pay rates, some warranted, some unwarranted, and also the level of spend going to agencies. Our two highest users of agencies, in fact, our mental health trust, which I think really underlies the workforce vacancies in those organisations, is a certain percentage of that goes straight into the agency. We need to be reducing the amount on agency, and I do think a way we can do that is working better together.
David Purdue, Executive Director of Nursing.
Thank you, Chair. Thank you, Tom. So in terms of workforce, we are planning, myself and Annie, an event in November to look at actually all the different elements of workforce, and a big part of that is widening participation and looking at how we get more people who want to come in to work for the health service. Obviously, from a nursing perspective, which is the biggest area of workforce, there's a number of initiatives already underway. What the area has done really well is in terms of international recruitment, which has done exceptionally well and continues to have a strong pipeline in terms of registered nurses. There are other work that we need to do, and especially around that combined workforce for health support workers between health and social care, and how we have a joint strategy, because that's a large area, and actually getting that right in terms of the messaging. There's lots of messaging at the moment that you can earn far more working for Amazon, for Lidl, but actually when you look at all the package that the NHS provides and local authorities provide, actually you have a much better deal coming back to work for the NHS. So there's work that we need to do, but one of the key things we need to do is work with Health Education England in terms of the offer from our higher education institutions, but also from local colleges. So there's a vast number of work streams that we are looking at to improve that workforce. But there is some work that we do need to do around differential in rates in terms of agency spend, and how we look at a bank approach across the ICB.
Thank you very much indeed, David. Is there any other comment? I don't see anybody else wanting to speak, so we'll move on with thanks to David Chandler for excellent report. Thank you very much indeed. On the remaining items, the item 21 is a series of reports, annual reports from the former clinical commissioning groups that did not get the opportunity to enter the public domain, given the speed of which the changes were introduced. The other 5 all did. So I ask you to receive these. If there are any points anyone wants to raise now, please do. Any follow-up points you want to raise, please make contact with us. Anything you want to flag up in them that we should consider on a future board agenda, tell us. So there are any comments now that anyone wanted to raise? Thank you. Claire Riley, are there any questions submitted by members of the public?
No, Chairman.
Thank you very much indeed. Are there any other items of business from the board members? No, thank you. In which case we can close the meeting, and maybe you can confirm when we have gone offline